Good morning, everybody. 23rd of September 2024. This is the Health and Care Overview and Scrutiny Committee, originally scheduled for the 30th, but there has been a switch for today. Welcome those that may be watching on webcast. And I'm Councillor Richard Cox, and if we could go straight into our agenda, please, with apologies.
Good morning, Chairman. I've received apologies from Councillors Peters, Chapman, Long, Hewitt and Perry.
Okay, thank you. Moving on to declarations of interest. Do we have anything?
Chairman,
Councillor Edgeley?
yeah, Partner Governor to Midland Partnership Foundation Trust from the county.
Thank you. And I think it's always wise to think, if anything does come to mind as the meeting progresses, that we declare it as and then, just if it comes to mind. So if we could look at the minutes, item 3 of the meeting held 29th of July 2024. Can I take those as an accurate assessment of that meeting? Councillor Jessel?
Yes, Chairman. Yes, I think they're an accurate account. I just wanted, if there was any feedback on page 12, the recommendation was a letter should be sent to the relevant Secretary of State. I just wondered if we could have feedback under that minute. Thank you.
I can confirm letters were sent both to the Secretary of State for Environment and the Secretary of State for Health. To my knowledge, and I'm pretty sure Zach will confirm, we have not had a response.
Right, okay. Has there been a change? I'm just wondering whether, with the change in government and change in cabinet members, whether it may be worthwhile resending. That's the only call.
The letters were to the new government, so we'll give them a little bit more time after their conference, and we will necessarily chase them up, but it has gone to the new Secretary of States.
Yeah, can I just highlight that just in the last set of minutes, Councillor Steve Norman isn't recorded to have attended, but he did attend. So with committee's permission, I will amend the minutes.
Thank you. And I think we are expecting Councillor Norman today, so perhaps held up in traffic. Okay, so with that, I'll sign those minutes. Do we have them in front of me?
Yeah, here.
Okay. So we move on to item 4, which is the West Midlands Ambulance Performance Update. If I could introduce, we've got Vivek Kashu and Murray McGregor, and did we say somebody was coming online? Okay.
Dr. Alison Walker, our medical director, should be joining us online, but we won't the whole proceedings. We'll just carry on with Alison.
Yeah, if we may, please. Yeah, thank you. Otherwise, we'll struggle getting through this agenda. Over to you then, if you'd like to present a report, please.
Yeah. Good morning, everybody. There's a few new faces, I think, around the table, so we'll just introduce us. So I'm Vivek, Strategy and Engagement Director with West Midlands Ambulance Service.
Good morning, I'm Murray McGregor, I'm the Comms Director for West Midlands Ambulance Service.
So I've just pulled together a few brief slides which just kind of illustrate where we've been around performance, response times, activity, handover delays, that kind of thing, the sort of subject we normally bring to the committee. So I'll just sort of summarise the slides, and then of course we'll get into, no doubt, some debate and discussion. So first slide here just looks at our activity. So the blue bars are the individual, what we call incidents, are individual cases to us, individual patients, and you can see since 22-23, our own workload has reduced a little bit there. So you can see previous 2 full years, our own workload has reduced, and you can see a gradual reduction in the numbers of patients also going into hospital. I think there's a couple of things to that. You know, we're working very hard on alternative care pathways and trying to get patients into the right place to avoid taking patients to hospital, and we've got some really great community-based services here. I think though we shouldn't lose sight of, there's probably a group of patients who think, you know, I just won't ring 999 as well because of all the sort of narrative around long ambulance response time. So we're not by any means, we do recognise that as well. So I suspect that story of reduced activity is probably a combination of the two. So moving along, this is, by the way, these slides relate to Staffordshire and Stoke-on-Trent. It's not us as a region, it's Staffordshire and Stoke-on-Trent, I should have said that. The next slide are the lost hours to handover delays. So the orange line you can see is the current year we're in. The black line underneath it was last year. So you can see for most of this year, so from April onwards, it's been trending considerably higher than where we were last year. That's clearly not a good thing. But you can see the month of August saw quite a sharp reduction, which is a good thing, and I'll come back to why that was a good thing in a moment. You can also see it is still quite a bit higher than where we were in previous years. But as I say, we'll come back to where we were in August and what does that mean. This slide here is just representing the lost hours. So each blue bar is the number of lost hours across. So it goes back a few years now, so you can see where we've been a few years ago, where we are now. So clearly, you know, this year is not as bad as previous years, but it's considerably still worse than where we were not that long ago in life and times in the NHS. Right, so response times. This is category 1, and you can see right at the tail end, we're beginning to make some inroads into category 1. Now, category 1 is clearly, you know, that's life in imminent danger. It's cardiac arrest and those sorts of things, but it's very, very small numbers as well. It's very small numbers. I guess the good news I'd like to talk to the committee is clearly there's a bit of an improvement there, but there's actually been quite a considerable improvement in category 2 response times. So category 2 response times is around about half to 2/3 of our workload. Across every ICB in the region for August, we delivered better than 30 minutes. For Staffordshire and Stoke-on-Trent, we delivered the 4th best response times in August in the country. So Black Country, Birmingham, I think one region northwest, then Staffordshire and Stoke-on-Trent. So we've considerably improved response times over the last few months, not just in Staffordshire, but across the region. They're still not where they used to be, though. So the standard for the NHS and for the ambulance sector for category 2 is an average of 30 minutes. We're used to delivering 18 prior to COVID. The government changed the standard, the prior government and this current government moved it to 30, and we're comfortably at this point achieving that. So year to date across the region, we're pretty close to 25. That's not the same in the rest of the country. Other ambulance services aren't in that area. We're probably the best performing in the country at the minute on response times and actually achieving the national standard. You can see also for category 3, which is also really important because that's typically older people, fallen at home, that kind of thing. The response times, so the black line is the average response time, the green line is at the 90th centile. That's improved considerably as well. Final slide there is just because it was of interest to the previous committee. That's just lost hours by hospital across the region for us over a course of time. So that's just there for your information. So as I say, August was very helpful to us because clearly it contributed to the improved response times that we had. You know, less hours stuck outside hospital means more hours on the road. But since we were last here, I think it was November, if I cast my mind back last year now, a lot of things have happened. So we had practically had our CQC inspection, but we hadn't had our report at that stage. As colleagues and committee members may be aware, we were downgraded in that CQC inspection from outstanding to good, and a lot of that was driven by our response times at that point in time. And we received what's known as a Regulation 12 compliance notice, which is a legally enforceable compliance action about, and it was specifically on delivered a Category 2 response time. So we had to produce an action plan and a performance improvement plan. We did that ourselves because, of course, we've got to respond to that. We can't just take a Regulation 12 notice and not respond to it. So we instituted at that stage, so we're going back to now February, March of this year, quite a significant plan around redeploying our own resources. So we've had, you know, a number of staff doing all sorts of things who are trained, qualified paramedics, so they were put back onto the road. So people who were in sort of secondments and acting roles were redirected into frontline response. And we also had and have a significant recruitment plan for around about 338 additional staff, which are sort of being phased across the year. So our additional resourcing, and you can see with the improvement in August around the handover delays, our response times have considerably improved. Now, that's not with its own issues, though. So we are ourselves very pleased about the improvements we're making in response times. We want to continue to do so. We've still got more staff to come in throughout winter. The issue is, though, it's the finances behind it, because 338 additional staff comes at a considerable cost, and that's not currently within our financial envelope. So we're still in long and sort of protracted discussions with our commissioners in NHS England around the financial sustainability of that. Now, as a board, we just knew we had to sort out the response times. No issue with that. We can take for more time to sort out the finances behind it. The response times was an immediate imperative. We couldn't carry on the way we were. So we're in, as I say, we're in a, you know, quite a lengthy discussion with NHS England, our commissioners, and the commissioners across the region, because they're a regional service. It's not just in one locality about resolving the financial gap that's being produced by it, but the immediate, I guess, message from me is that we have improved our response times, and considerably so. So we finished last year, the average for the year last year was 36 minutes across the West Midlands. As I say, we're close to 25 on the Category 2 standard, which is the main sort of standard we're monitored against. I'll perhaps pause there, Chair. That's like a summary of the slides, and happy to take any questions or queries that committee members may have.
Many thanks for that. Welcome, Councillor Norman. We've noted your arrival, and there was an amendment to the minutes to say you were present at the last meeting. Thank you. You may be aware that Alison Walker has joined us, so welcome, Alison. Any questions that do we have? Councillor Norman.
Yeah. Can I just apologise on behalf of Staffordshire County Council's Highways and Publicity Department for being later than even I expected in Stafford. The second thing is to say, in the references to the, I hope there's more text next time, and you must do this report to all these other health and review and scrutiny committees around the West Midlands, though I couldn't find one that you did recently. So you've got the tables here, but for people like me who don't quite fully understand them, if there's a bit of text as well, that would be great, which you could use presumably everywhere you went, really. I'm just suggesting that. In the reports I've seen, because I had a recent other complaint, my experience is that they don't match the figures, the actual experience of an ambulance arriving, and I've had to put a complaint in on behalf of a resident recently. We're not going to talk about that except to ask the question about the auditing of the figures. When you have a call, you classify it, and then I'm not sure when the audit comes in, whether that's after the event and you say check, just a way of checking, or is it checked before action is taken, before, you know, and also I'm not sure about the paramedics and ambulances as well, where they come into it, because fortunately for me, with my heart attack, paramedics were there quite quickly and then ambulance not long afterwards. But if you could help with both those, if you understand those questions, I'm sorry for...
Yeah, sure. So we're incredibly highly scrutinised by a variety of people. So as part of our standard operating, our call assessors have a number of calls assessed and checked by a clinical audit team to assure that they are taking the call correctly, so that we know that we have very high standards. We have the fastest call taking in the country. We know that. That's, again, independently verified by NHS England and our commissioners. The system is very much automated, so when the call hits the switchboard, the clock starts, if that makes sense, and we don't have any way of addressing that. It just happens and it logs itself on a computer system. Equally, when a vehicle starts moving, that's logged automatically. When it arrives, that's logged automatically. When they leave scene, it's logged. When they arrive at hospital, it's logged. When they hand over their patient, it's logged. When they clear from the scene, that's also logged. And when they hand the patient over, the crew actually provide a PIN number to the hospital, so that the hospital can then put it into their system, so that we can audit how long it takes for the crew to, from handing the patient over until they're clear to then move on to the next job. So we're very highly audited all the way through. In regard to a paramedic, we're very fortunate in the Midlands that we're the only ambulance service in the country that's a paramedic on every vehicle, and we're very proud of that. Clearly that helps us greatly with our ability to not take patients to hospital. We have either the lowest or the second lowest conveyance rate in the country, depending on which week you look. And that clearly takes a great deal of pressure off the hospitals. So we take fewer than 50% of our patients. It's about 48% of our patients go to hospital. About another 4 or 5% end up going to somewhere other than hospital, but we do convey them. So it might be a minor injuries unit. It might even just be to a GP surgery if that's appropriate. The rest, again, we're country leading as far as the number of patients that we don't actually send anybody to. So we have a team of very experienced paramedics and nurses that work within our control rooms, and over 20% of our calls now we don't actually respond to physically. And that's either they provide the assessment and treatment over the phone through advice, or they will try and use a range of other services. So they might get an urgent care referral into one of the other NHS services. So that could be a falls coordination team, an occupational therapist going out to the patient, or indeed making them a direct appointment into a same-day emergency care. Sorry, it's a lot of jargon. So instead of going to A&E, they go straight to a ward to be seen by the specialist on that ward. So the whole system is audited all the way through.
Just about the category, because if the patient is put in the wrong category, then the ambulance is going to be take longer to get there, right? So I just wonder how that works. How well is that checked? Because that needs to be not, much later, and I don't think that can be done automatically. So I just wonder how that was, because I've had cases. I know there's cases, and this is what worries me, is that my practical experience is not the same as the figures that you have here. But if you could help reassure me on the getting the category right in the first place and understand the problems. The other question I'd like to slip in, which is, because you may have mentioned it before, I realise how busy things are. Just how many ambulances do you need? I can lobby MPs, you see. How many ambulances do you need? That's the other one.
So let me start with the last one first. So, because that's the easy one. So at peak, we aim to have 400 ambulances on the road. That's our estimate as to how many we need. But the number of ambulances on the road varies by every quarter hour, because it's a very fluid system. But at peak, it's close to 400. So as far as the call categorization system is concerned, it's a very risk-averse system, incredibly risk-averse, for the very reasons that you highlight. So we use a system called NHS Pathways, which was designed and built by the NHS to categorise calls. There is a second system called MPDS, Medical Priority Dispatch System, which is an American system, which was messed around with many times by the Department of Health over the years, and we moved away from that about 10 years ago. The system that we use is, I think, very good. It asks very open questions, whereas MPDS asks very closed questions. So it takes a little long. It's good for patients, though. MPVS asks very yes/no questions. Pathways ask much more open questions, which allows the call assessors to get much closer into the details of what's going on. But it uses a script, and it tries to highlight the most serious conditions first. So the first questions you're asked are, is patient conscious, is patient breathing? Because if they're neither conscious nor breathing, you know that they're not terribly well, for fairly obvious reasons. So roughly 53% of our calls go into a category 2 pot. About 8 or 9% go into category 1. Category 4 is about 2 or 3%, and the rest are into category 3. The numbers have actually moved more to category 2 over the years as new research comes into play, and that pot has kept growing, which, as its pros and cons, it makes it more difficult for us to get to places more quickly because we have to get there more quickly in more cases. But I think the general view is that it's a good system that does categorize things well. Clearly, you can't scrutinize it there and then, but that's why we have a regular review of every call assessor's calls get scrutinized by a team that do nothing else but scrutinize calls to check that they are putting them into the right pots, if that makes sense.
I kind of thank you through the chair, but also I did watch all the little videos on your website and did read all the reports and so on. So, but those questions I weren't quite sure about. So thank you for those, and thank you, Chair.
Councillor John Jones.
Thank you, Chair. Thank you, gentlemen, for coming along again. You'll be pleased to know I'm not going to give you a very hard time this morning. It's the same story all over again, really. It's just been said. It looks like it's getting better. That's encouraging. That is really encouraging. But it's nowhere near good enough. I mean, we're still getting reports. I had a report last week of an 8-hour wait for a faller. The categories, it's an interesting point, the categories. Is that not automatically determined by the CAD, depending on what answers you give to the questions when you ring in? Because some of those still fall through the holes. I had a person told me they'd been promised a 9-hour wait for a code 22, a deceased. 9 hours. They're going to sit there with a dead body for 9 hours. Fortunately, when they queried that, it was somebody intervened and they didn't wait that long. So things can fall through the cracks because it's a case of, is the patient breathing, then the next question, then the next question, and it's a flow chart and the answer pops out at the end. So it's not infallible by a long way. Point was made about number of ambulances. The number of ambulances is important, but where they are is even more important. And sadly, they're usually in the urban areas because that's where most of the work is. And you know, I know I sound like a crack record, but generally in the urban, in the rural areas, there's no presence. So when a call comes in, you've got a minimum half-hour wait because it's going to be a 15-mile journey. Even on blue lights, that's going to take 20 minutes. And there doesn't seem to be any moves to reinstate any sort of rural presence, sadly. And I know all the reasons you give why and all that, but it isn't working, gentlemen. It's certainly not working as well as it was 6 or 7 years ago. And it's interesting the number of calls, looking at instance transport conveyance rate you've got. I'm looking at that chart. It looks to me like last year, the total number of incidents was as much different than it was in 2015-16. Now, we were told that, you know, one of the reasons that the delays are there is because the demand is up. That chart doesn't show that, unless I'm reading it wrong. So, as I say, I'm pleased that things are getting better. I'm still not happy that things aren't as good as they could be, and I'm certainly far from happy that the rural areas are still being not neglected, but they're not a priority. We always get presented with average overall performance figures, and that isn't reflected in the Staffordshire Moorlands, and certainly probably not in other areas like Worcester and so on. So thanks for coming, thanks for the presentation. I know what you're going to say now, but you know, I still think your direction is wrong, and it really needs a major rethink. And also, just quickly, I would never ever question the competence of crews, but it does worry me that you've got a hell of a lot now, of young, very inexperienced paramedics. A few years ago, if you were a paramedic, you'd been on the service at least 10 years, because you'd done probably 2 years as a care assistant, then, I don't know, 5, 6 years as a tech, and then you were a paramedic. Now you're coming straight out of school, 2-year course, bang out there as a paramedic. I mean, just anecdotally, I'll tell you of an incident that happened last week. An old lady with sepsis. She was red flagged for sepsis, and the crew were going to leave her at home. It was only because her husband is a retired paramedic, and he insisted that they take her, that lady's still alive. You probably know the case. He is I know that paramedic is not the easiest guy to deal with.
Councillor Jones, I don't necessarily think we ought to be going into...
I'm not naming any names, but it's an incident that happened, and it's a worry when you get a crew that says, go and see your doctor.
Yeah, but I think there's also a question on ability, and I think...
I'm not. It's experience,
well,
Richard. That's what it is.
Yeah, well...
And 99, you know, that was an isolated incident, but there probably are others, and it worries me.
We all have to start off somewhere in life.
Thank you. I'm done.
I'm not too sure we actually got any questions there, so I'm going to call in Councillor Anne Edgeler.
Thank you very much, Chairman, and thank you very much for your presentation. Yeah, I mean, my question really is, are you prepared for the winter period, the oncoming winter period that we've got coming in front of us? And I say that because you say you've got 330 additional staff, and you're talking to NHS England about it. What if the answer comes back and says they can't support that, and what have you? What's your contingency plans to keep everything on board? And
Could I just take those 2 questions first?
yeah, fine. Thank you.
So the first bit around the winter plan. So our winter plan is essentially around building up our resourcing and resources. And we phase the recruitment to kind of layer in throughout the year. So it goes all the way into December. So we'll have, with that level of resourcing, as Murray said, you know, we'll be pushing around 400 ambulances a day, which we think is, practically speaking, as much as we can realistically put out in terms of how do you recruit so many staff, train them, get them through and get the vehicles out. The other thing that's also happening in parallel to all of that, on the other side of all of this, because we often come here and talk about handover delays and things like that, the Midlands region is now attempting to adopt a model that has been adopted successfully in London. So in London, no patient, with the occasional exception, waits more than 45 minutes to be handed over. That's a backstop in London, and that's a standard that all bar one hospital in London is signed up to. So that's a standard now that is now the Midlands NHSE region is working to adopt in the Midlands, with Birmingham, I think Staffordshire, Nottingham, and it's outside the patch. There's a number of hospitals to go first, and they're due to go first in October. So NHSE are also pushing systems really, really hard to make sure they release the ambulances in the first place. So irrespective of that happening, we know we need to put out our resources and do what we can do that's within our gift. The other bit about the handover delays will greatly assist us as well, and that's a piece of work, as I say, across the region. As to what will happen about the money, well, we've already taken the action. You know, our board supported an action to increase our level of resourcing. What we will do, though, however, if the handover delays were to suddenly reduce, we can tailor that recruitment plan and we can reduce. But actually, our confidence in that happening was very limited, and that's why we went with such a substantial recruitment plan in the first place, to mitigate what's going on over here with the lost hours. If the lost hours suddenly compress, we'll reduce our recruitment. If they don't, well, we've already got the staff then in place to keep our response times where they are. So I'm not saying it's a comfortable place by any means. It's not, because clearly the NHS, like all other public services, its financial position is under considerable scrutiny, as is ours. But we think we're doing the right thing by patients first and foremost by putting out the resources.
Thank you for that answer. You know, on page 22 of the report, I mean, Roystoke, the lost hours is 2,000. It's very high, actually. You know, what is the reason for that, please? And also, can I just make a comment that years ago we used to have the chief exec come to these meetings, Mr. Anthony Marsh. We've not seen him for years now, so I ask why he doesn't appear. Thank you.
I wonder whether I could bring Dr. Alison Walker in at this point to talk about the lost hours, as she's been doing quite a lot of work around that area.
On both sides of the doors at the emergency department. Sorry. I thought somebody was going to say something. Do you want me to carry on?
To start again, we've only just got your sound working.
Oh, sorry. Yes, I'm Dr. Alison Walker. I'm the Medical Director for West Midlands Ambulance Service, and I'm also an emergency medicine consultant. So I do understand the problems on both sides of the doors at the hospital. And we've done a lot of work over the years. Is the sound okay?
Yes, it's fine.
Okay, carry on. What we do know is that the hospital handover delays started to really escalate in 2019. And prior to that, we delivered all the time targets for all the categories. And I know you spoke a few minutes ago about NHS Pathways. So NHS Pathways was a system developed by clinicians, primarily GPs nationally, which was then adopted by the ambulance services system. So it is a clinical system by development and was stress tested to a significant level at the time. And as Murray said, we do audit. Every single call taker receives a regular audit, and any instance we audit the calls in depth for those instances as well. But what we do know is that the handover delays have a massive impact, not only on our patients, and most importantly, our patients in the community who are waiting for an ambulance. So there is nowhere in a hospital that is less safe than being sat at home with chest pain waiting for an ambulance to come on your own. And so we're working in partnership with the hospitals, and I've done a presentation for all the regional medical and nurse directors, which was developed in partnership with Vivek, the nurse director, our paramedic director, and others, to talk. And I know somebody said there's a lot of numbers on these slides. We are very good at putting a lot of numbers on slides. And, you know, when you understand what the numbers mean, then it does help. But there's a lot of patient stories as well behind these numbers. So we know that people are coming to harm because we cannot get to them on time sometimes. And the reason we cannot get to them on time sometimes is because those ambulances are being used as cubicles outside a hospital, which is not an acceptable position. And our staff are being held looking after patients for up to 3 hours or longer at the end of their 12-hour shifts. And that doesn't happen to any other band 5 or 6 clinicians anywhere else in the NHS, that they're held by another trust to look after the other trust patients. Because it's well recognised by NHS England, the Royal College of Emergency Medicine, and everybody else, that the patient becomes the hospital's patient the moment they arrive outside the emergency department. And the clock for the emergency department starts from the moment of the ambulance arrival. It's the same in my emergency department, same in every emergency department. So, as I said, we've been working together with the hospitals, and I think it was Vivek that said there is a rolling programme led by NHS England region medically, and that's led by somebody who used to be a paramedic clinically, so they also understand the problem. So is there anything else that you'd like me to expand on in terms of what we're doing at the moment? I mean, the most important thing for me is we reduce these handover delays back to the 15 minutes they're supposed to be as a maximum, because that releases our ambulance and clinical capacity to respond to people all over the region, including in our rural areas. Oh, lovely, I can see you all. So, but I'm happy to take any specific questions about how we do things or how we're working with the hospitals.
Thank you. Councillor Edger, do you want to come back on that?
Just to say, just to clarify, do I take it then that it's waiting for the beds in the hospital that is causing this long delay? Yeah.
So I think if you were to ask the hospitals, they would say that the main issue is actually being able to get patients home. So we know in some places it's over 15% of the bed base has patients in it who are actually waiting for social care to get the right packages in place for these people to go home. So while there is sometimes an issue with the time it takes to get a patient from an emergency department to an assessment ward, actually probably the bigger issue is how to get the patients home in order to free up the capacity to allow the patient to go from the ambulance to the emergency department to an assessment ward, and then assessment ward to a specialty ward, and then a specialty ward home is kind of the whole urgent and emergency care journey for that patient. And the shorter we make each of those steps, the better. But there are definitely problems reported by all of the acute trusts in terms of getting the patients home and having social care packages in place for them, because obviously they want it to be as safe as possible for those patients to get home.
Okay, I've got Councillor Julia Jessel on my list next. Julia.
Fine, thank you very much, and thank you for that explanation. Can I first of all start off by saying I acknowledge the fact that there has been significant improvement. And the last time we met was the 13th of November, because I'm one of these sad people who make a note of what everybody said. And I think then it was highlighted about the distribution of your resources. We're a rural county. All your data gives us an overall picture. And I think the comments, Dr. Walker, that you've just said has again given that global picture, because within Staffordshire we have an integrated social care and NHS system. Our partners are Midlands Partnership Foundation Trust, and my colleague Councillor Northcote there can tell me if I'm wrong, but when I was cabinet member up until April, the delays to discharge within Staffordshire were very minimal because we have that integrated system. There are always those complex cases, but actually delays to discharge of care within Staffordshire are not necessarily the same as within the whole West Midlands. This is the first point I will make, and it was raised in the 13th of November, and my councillor over there has raised it again. And I don't want to seem too parochial, but I'm elected as a Staffordshire County Councillor, and this data does not give me the picture of what your performance is in Staffordshire. I know the ambulance service, because I used to work in the NHS many years ago, are very data rich. And actually, it's quite within your capability to be able to give a breakdown of performance within each area. And I think, Chairman, if I may propose that actually members of this committee are provided with that breakdown, because like many councillors, you get members of the public challenge you, oh, you know, my neighbour had to wait X number of hours for an ambulance. This data does not give me any information or any comfort that I can actually challenge that. So, you know, that is something that I think as an overview and scrutiny committee, it was raised in November. We do need that breakdown of information and not a global West Midlands ambulance service figure, because I think that will give us a better picture of what is happening. Now, also in November, I raised, are we making full use of the Community Rapid Intervention Service? And it would appear that you were, but raised, you know, it could do with further investment to make it a 24/7. I can confirm that I did raise that. Whether that has been addressed, I don't know. But the other thing that is missing on your table on page 22, again, for a Staffordshire perspective, I am aware some of your ambulances do take patients, and I represent a division in East Staffordshire. Obviously, Derby Hospitals is one of our main acute hospitals that is missing from the table. Now, when you look at the table, Royal Stoke and the hours that your crews were held up there is significant. And whilst improvements have been made, it is still a significant loss of productive time. And I appreciate the fact that this is must be one of your biggest bugbears. When you compare them with other big trusts like the Queen Elizabeth, it's still far more than that. And the QE Hospital in Birmingham is huge and covers a huge area that is, has areas of great deprivation. I used to be chairman of North South Health Authority, and I know the hospital trust there always said we're a special case. They still haven't improved as much as they should be. And at the meeting last November, it was mentioned that actually Walsall Manor Hospital Trust had made significant improvements to how they dealt with incoming patients, which meant that the number of hours that you were held up there was minimal. And I think it was suggested that we hoped people from Royal Stoke would visit, and I think there were people from the ICB present at that meeting, to go and learn from good practice elsewhere. I don't know, I'm probably asking the wrong people. I'm not sure whether you're able to, but again, if you're not able to confirm whether that exchange of good practice ever happened. If not, I would ask the chairman, if I may, whether we can make inquiries that following that discussion on the 13th of November, whether representatives from Royal Stoke actually made the effort to go and find out how other people do things. Because I'm a great believer in not reinventing wheels, but actually learning good practice from others. So those are the questions and the points I would like to make at this stage, Chairman. Thank you.
Thank you very much, Councillor Jessel. And yes.
Blimey, I think I got most of those, so apologies if I miss any of your points out. So delays, yes, Royal Stoke remain one of our most difficult places to hand over. They're not the worst this month, looking at the data, but they're second worst in the region. To be fair to them, they do have an issue in that they are the only big hospital for miles around, and therefore everything goes there largely. So they are, unlike the Birmingham hospitals where there are 5 or 6 hospitals within 10 miles, they are the only hospital for many miles around, which does bring certain challenges to them. You're very right, the CRIS service is excellent. We've very often championed the nature of what they do. I have to say, I don't know whether they're 24 hours yet. It would be useful if they were. Certainly, when we try and push patients to urgent care services elsewhere, we get about a 50% bounce back of where, and that's region-wide, and I apologise, it's a region-wide figure. But it is about 50% of them do come back where we just can't, we think that they could be dealt with by other people within the NHS, but for those services aren't there. And the night time is a particular problem for that, without question. Postcode, we have the data down to postcode. Whether it's actually terribly helpful to you might be a different question. And we're happy to provide that data to you if you would like it. What I would say is to take it with a pinch of salt, because we are not commissioned on a postcode basis. And if that were to be the case, then our level of resourcing would have to be raised very considerably. We did do this work in Shropshire some years ago, and to get to a postcode basis level of service, you would have to double the number of staff that we have. Or in Shropshire, we would have had to double the number of staff and increase the fleet by 2/3. So there is a very considerable cost involved in doing that. It's possible whether the NHS could afford it is perhaps a different question, and those are debates that I'm afraid we're not. That's a bit further up the food chain to us, and you may wish to lobby for that. I don't know. On a more positive note, Stoke and Staffordshire actually put themselves forward. Vivek mentioned the 45-minute handover campaign that's going in. Stoke and Staffordshire were not due to go as early as they are. They actually asked to go forward in October, which I think we very much welcome. We would obviously like them all to have gone live in October, but we recognise that there is particular work to do. But I think the very fact that Staffordshire and Stoke-on-Trent want to be at the forefront of that is very positive, and we clearly hope that that will have a significant impact. To pick up an earlier point, one of the big issues is the hospital handover delays, and it does impact particularly rural areas. Particularly rural areas are by far the worst impacted by those hospital handover delays. We know that because about 50% of ambulances free up within a rural area, they are then in a rural area to respond to another patient. If we end up stuck at hospital, then those ambulances have to then travel from Royal Stoke to a rural area. That inevitably is going to add on the amount of time that it takes for us to get there. And therefore, rural areas are particularly badly impacted by those hospital handover delays. I think I've covered all your points.
Just one bit about Walsall. We ourselves put Walsall on a pedestal because we talk about 45 minutes. Well, Walsall achieve that largely now. They're not told to do it. They already are performing at that sort of level. Whether there's been a recent visit, I can't comment specifically from Stoke and Staffordshire down there, but I myself presented to a room of around about 100 emergency medicine consultants and specialist doctors in the West Midlands with the Chief Operating Officer from Walsall, and there were colleagues there from UH&M and Derby and Burton and everywhere else, where the Chief Operating Officer there talked to their model of care and how do they get patients processed in the way that they do. And actually, there's no magic. They've just got a very good system of the rest of the hospital underpinning their emergency department, and simply by just saying yes. So when they've got a patient who needs to be in another part of the hospital, they don't have to jump through hoops to get there. They can refer and the patient just goes. I'm boiling it down. It's clearly a bit more complex than that, but basically they've got the right kind of behaviours and processes and practices to underpin their emergency department. The other comment I would just make about why are there delays in Staffordshire. Our ambulance activity has come down quite a bit in Staffordshire. So when I used to work at Royal Stoke up until 2018, a normal day for me was 180 to 220 ambulances a day. Now it's more like 120, 130. The number of ambulances going through has been considerably reduced. What we're not cited on, but I believe to be perhaps the bigger issue, is what are they getting by way of self-presenting patients, and that's not something we're cited on. So it's one department. There's clearly two streams of workload going in. So whilst we're taking fewer patients in, they may well be having others turning up themselves of their own volition. They need to be seen and sorted as well, don't they? So that may be a discrete issue that the committee will pick up with UH&M another time, I suspect. Thank you.
Thank you. May I bring in Alison, please?
Yeah, sure. I was just going to pick up on a couple of areas. So the first thing is the CRIS system is well recognised for being an excellent community system. And when we talk about what we know works around the region, then we frequently talk about the CRIS system in terms of being an effective community management system, so that people who can be managed in their own homes are being managed thanks to the communication that we have with CRIS. So it is one of the flagship areas, I would say. In terms of the urgent community referral systems, they were commissioned nationally to be 8 a.m. to 8 p.m. 7 days a week. So I think that's part of the problem, is that the commissioning for them was national originally, but the expansion of them would have to be more local. So I think it's meant that there's been all the conversations that set it off in one place, and then the expansion conversations need to happen in different places. So that's maybe why we haven't seen expansion yet, but we would really welcome expansion of CRIS because it's such a fantastic system. And then just to touch on the good practice sharing, we do, as you know, share the good practice that we see around the region. So I presented to the regional medical and nurse directors to some of the ICB systems about what we know works for our patients, and by our patients I mean all of our patients in the community who are waiting for emergency ambulances. And NHS England also led, and I was delighted actually, because I don't know about the rest of you, but we seem to have listened to, you know, what's not good for years, and seldom, I sound a bit like Jon Snow, don't I? Seldom hear about what works well, but there was a piece of work that looked at the best 6 urgent and emergency care flow systems in England, and then shared that information with all the regions. And so that information is out there for any trust that wants to have a look at it. And that was from an ambulance service perspective, it was from an acute trust perspective, and it was from community services perspectives, and it included processes, systems, and culture. So there is learning out there that's openly available and has been shared. It just depends how much of that is picked up on, I think, in each part of the system. So it's just really to let you know about that as well. Thank you.
Thank you, Alison. Can I bring in Julia Jessel, please?
Yes, thank you very much, Chairman. Just to sum up, because I think it's important that we do pick up on some of the issues, I would like to propose that, and for those who don't know what CRIS stands for, it's Community Rapid Intervention Service, that actually this committee write to the ICB to ask that serious consideration be given to expanding that service to cover 24/7, because it was mentioned and it has been said, and I'm aware that it's very well thought of.
Could I just add, if there's a letter or a communication to go, it's not just the number of hours, but it's the scope of service. What are they actually able to absorb and do? Because there's something about how many hours do they cover, but there's also something about what other sorts of patients are able to deal with as well. So just just to add to that, so we've referred, just from our validation team, nearly 400 or so cases across in the last 7 days. They've been able to take less than half of them off us. And that's also partly to do with what kind of skills and capacity have they got, as well as the scope of coverage. You know, it's just, that was the point I was going to make.
Yeah, I understand that, and it is the skills of the team, but I think it's a matter of raising that actually no health service should operate on a 9 till 5, set 5 days a week. We do need to have it covered for a broader space of time. That, I'm sure, is not going to happen overnight, not least because of recruitment, but then we need to, you know, challenge what skills are available and facilities to be able to deal with more people outside of hospital environment. I'm a great believer in, what's it calling, peeling the onion. You do things a bit at a time, because if you try and do it in one step, you don't go forward at all. So it's something that was raised in November. I did raise it with Dr. Richard Harling and Tracy Shuren, and I think if this committee supports such a recommendation, that actually that is something we do. I recognise the data for Stoke and Staffordshire may not be 100%, it's by postcode, but I think that will give us a better feel for the situation within our county than just being presented with West Midlands wide data. So I think it would be helpful, Chairman, if we could have that information.
Can I just comment? I did say at the beginning of the meeting, this is Staffordshire and Stoke-on-Trent data. It's not West Midlands regional data, but we can certainly give you response times and performance by postcode, but this is Staffordshire and Stoke-on-Trent data, not West Midlands
But
regional.
it's within, Staffordshire and Stoke-on-Trent is a huge county. And as I say, the area that I represent, most of our patients, if they don't go to Queen's at Burton, go to Derby, and that's not included on your chart. I have raised this before. The NHS sticks to specific boundaries. We are in the middle of the country. A lot of our patients are taken by your service to out-of-county hospitals. And Derby, quite a significant number of seriously ill people do go to Derby hospitals from the east of the county.
Okay, yeah. Thanks, Councillor Jessup. It's a very valid point, and when I summarise, I'll look at the proposals and get committee's consent on them. I've got a list of speakers wishing to question. I've got Councillor Sylvester Hall, Charlotte Atkins and John Jones. So if I can call in Councillor Sylvester Hall, please.
Thank you, Chair. Can I also just add my support as well to the localised data? I think that is something that we have talked about extensively in the past, and for me, it is how we target the resource that we have afterwards and target our minds as well into those. The other part that I just wanted to also comment on as well was page 22. The data on there, I think, is also very insightful, but the context with regards to the volume at each of those places, I think is also critical to how we can look to support, and we've mentioned it already today, but the sharing of the best practice. You know, I'm aware from a recent unfortunate visit to New Cross as well that there is now the ambulance offload, and that's the way that the turnaround happens very quickly in those particular areas. But when we look at the data, we can see it for the majority, all but one, I think it's reduced. How we make sure that that information is passed over. I just want to know who actually oversees it. Where does the ownership lie to make sure that those conversations are happening? And I appreciate that's not necessarily with you, but certainly it would make your lives a little bit easier and the experience of the patient a whole lot better as well. If I just can move on to the question specifically on here, you mentioned about the August dip and the trend that we've had at this precise moment up till August. And I was looking at the trend that it was following previously, it's still higher. You've also alluded to about people making their own way, that there is that concern because of the media reports that people are having to wait 9 hours, 8 hours, that they're actually self-presenting. And just to get, again, your insight at this point as to how much you think that's having an impact, and if that's something with that August trend is my specific question, please.
I mean, it's a bit hard for us to sort of specifically measure. I guess two points I would make. In a different region, I've done it myself with my own family. So when I've had my own father who was unwell at the time, we didn't ring 999 because we just didn't think there was any point, because we could manage him to get him into the car and take him to hospital. And in some respects, you think, well, that's not the wrong or bad thing, actually, if we can manage ourselves. Perhaps in a different time, we may have considered 999. What I would say, though, is that with our response times and our escalation levels being improved, so our escalation levels being down, what we're not having to say to patients who are ringing us is, look, you can have a really lengthy wait for an ambulance, make your own way. We ourselves are not saying that to patients nowhere near as frequently as we had to do in the past. So when patients were having a very lengthy wait, we would have to say, look, there's going to be a really long wait for the ambulance. Are you able to make your own way to hospital? Rather than making them just wait at home and suffer even more. We don't have to do that because our escalation levels have reduced and our response times are better. So us having better response times contributes to fewer patients in that regard, perhaps turning up to hospital. But I think over the last few years, and national and local media being what it is around the state of urgent and emergency care and ambulance response times, I don't doubt there must be other people who, like us, thought there's just no point ringing, we'll just make our own way. And if you're to talk to emergency medicine consultants, Alison will have her own view about how sick people are who are in their waiting room, who've made their own way to hospital. And that's perhaps also a bit of a proxy of who maybe should have called 999 but didn't, but made their own way. So waiting rooms can have some really sick patients in there now, which in the past they may not have done to the extent they do now. So I couldn't give you sort of numbers around it, but we're pretty sure it's a kind of a patient dynamic, a behaviour that is probably out there. Some of it's not a problem, because actually if you can, like us, if you can make your own way to hospital, not call an ambulance, that's not a bad thing actually. But for those who do need an ambulance, we would clearly rather that they did call 999. And that's why it's important to us that we do restore the response time, so people have the confidence in the service that they should have.
Thank you. Just before I come to Charlotte Atkins, it's just following on from that. Do you provide figures for stand down? Otherwise, when people have sent to hospital, do you then have a set of figures to where you've stood down your ambulances?
Yeah. Yes, we do. So we would know ourselves when so if we've told a patient to make their own way to hospital, then an ambulance hasn't been dispatched and the call will end at that point if they're prepared to go. If we've already dispatched an ambulance and then at that point, and we say to the ambulance, there's no need to now attend, we would know that as well. To what level of detail as to the causal factor behind why we've stood an ambulance down, I don't know. So we know when we've stood ambulances down, but as to the causal reason, I don't know myself. I'd have to look into that.
Thank you for that. Councillor Charlotte Atkins.
Thank you, Chair. I want to ask about the decline in the numbers of people, or the percentage rather, of people you transport, and to find out whether that is because people are making their own way to hospital, or is it because the calls that were made initially were not appropriate for an ambulance, or is it because you're using paramedics and advanced paramedics to treat the patient in the location? Because if you're looking at handover times, obviously the best thing to do is not to have a handover. So I really want to get behind those figures. I mean, it used to be, 50% were transported, and now it's down to 36%, something like that, at that order. So it's quite a significant drop. So if you could talk me through what has led to that drop, and whether you have statistics which can isolate the reasons, i.e. because people are making their own way there, or because people are treated at home, or because the phone call was inappropriate in the first place, and therefore they shouldn't have called for an ambulance. So how do the figures work?
Perhaps if I could ask Alison, if I could invite Alison to comment first, and then Murray and I might have some more to add, if that's okay.
If you could come in on this one, Alison.
Yeah, so I think the greatest change has been in the numbers of people that we telephone triage. So in other words, we take the call and then we think that there is a local community system that might be able to support the person better at home. And we have got some fantastic community systems around, not just through Chris, but through other parts of the regions as well, where particularly older adults, many of whom don't want to go to a hospital, can be managed in their community with conditions such as pneumonia or minor skin tears, those kind of conditions. So I think that's probably the biggest difference, is the referral through our control rooms to the community systems. I think the number of patients that we have the discussions, as far as I'm aware, that where we suggest or we say, would you be able to get yourself to hospital? I think it's a much higher proportion for the lower category calls. Obviously, the category 2 calls, we would always want to try and send an ambulance with a paramedic to the patient, because if you look at patients walking into emergency departments, including mine, people walk in who are having heart attacks, strokes, they have sepsis, all sorts. And the triage system that the nurses use in emergency departments to triage patients is a similar kind of system to the one that we would use in the ambulance services. So, for example, we all use early warning scores to decide how ill people are. So I think that it's a relatively small proportion where we say, and it's usually if somebody else has called on behalf of the patient and they're with them. So say I was to phone about my dad, then if somebody said, oh, do you think it might be possible to pop him in the car and get him to the emergency department that way, then, are you comfortable with doing that? And we always give safety netting advice and say, if there's a problem on the way, phone us back and we'll get to you. So we do safety net that as well. But I do think emergency departments are seeing some patients who normally you would have expected a paramedic to go to, who are not seeing those paramedics because there's been an agreement. And sometimes, you know, that means the patient is getting to emergency care more quickly than if they're waiting for a queue of ambulances to be released from outside a hospital. And we have seen some absolutely heartbreaking cases. So probably our best known one was there was a young man who was 18 who'd been out for an evening with his friends, hadn't been up to anything that he shouldn't have been up to, came back and collapsed on his drive at a time where there were 6 ambulances outside his local emergency department, which was not in your area. And so there was no ambulance available to send, and his friends started CPR on him. They did an absolutely amazing job, and then an ambulance responded, but not within the time frame it should have done. And between them and the paramedics, they got a cardiac output back on him, and he was taken to the local emergency department and went to intensive care, but sadly didn't survive. And his mum has had undertaken a big campaign about community access defibrillation and CPR, which, you know, is an amazing reaction to something that awful happening. But, you know, I think what we have to remember is that people waiting for ambulances are our friends and relatives. And, you know, many of these cases are utterly heartbreaking. And we know that if we had the handover delays reduced back to levels pre-2019, that, I mean, as you say, the number of critically ill patients, so there's no more heart attacks, strokes, road traffic accidents than there were 5 years ago. So we would be getting to these patients. This is the one thing that's changed, is the handover delays. And I'm not saying it's an easy solution. So I work in my hospital on our handover delays as well. It's really difficult. And we've invoked, you've probably heard of the one-up system to the ward, or the North Bristol model, where patients get sent up to a ward even though there isn't a bed available. And then what has seemed to happen in my hospital is that the patient who's waiting to go home is then sat in the television room for a while to wait for their daughter to come and pick them up. And the sickest patients are still having the beds. But it works differently in every hospital, and the solutions have got to be owned by each part of the NHS system. It's not my job to tell hospitals around the region how to do something. It's their job to find their own solutions, knowing that we need to move people through the system more quickly. And there is lots of evidence, both in emergency medicine and elsewhere, that the longer you wait for a bed if you need to be admitted, the higher the risk is of harm coming to you. Thank you. Hope that's answered the question. I can't remember where I started now.
Okay, I would like to follow up on your comment about community resources, because at the moment there's a review going on about urgent care. Has the ambulance service been involved in any way in discussion of urgent care, particularly in the context of a rural area? Because I fear that minor injuries units, for instance, will be closed down, and therefore, you know, clearly that will have an impact not only on the ambulance service, but obviously on the ability of people to be able to take relatives to hospital. So that's a follow-up question on that. But I'd also like to ask a question about the ability of an ambulance service, of an ambulance, to take a wheelchair in the back of an ambulance. Some people are reliant on having their wheelchair. It's their main way of moving around, not just in terms of outside, but also internally. And so and I have a case, which I'm not going to mention, where someone was delayed, not hours, but days, because her wheelchair could not be taken on board. It was finally sorted by Anthony Marsh, but what I want to find out is what are the problems with transporting wheelchairs and wheelchair users?
Vivek, you've acknowledged. Sorry, Alison.
Alison, if you wouldn't, I'll just pick up a couple of points made earlier. Then, if you wouldn't mind picking up on the wheelchair point in a moment.
Yeah, we'll do.
So just going back to your prior point about how many patients are going into what sort of areas, just because I've got some numbers in front of me. So we implemented, we've talked about it before, so I won't go over it all again, but that clinical validation team that validates clinically the less urgent calls, that did make a big difference in the system as to where patients are going. So in just 7 days, we've referred out 2,200 patients across services. That's in the West Midlands context. In Staffordshire and Stoke-on-Trent, there's 461 patients. Prior to that service being mobilised, most of those 461 would have had an ambulance being dispatched to them. So that change we did implement did start to fill the kind of workload out.
Where were they referred? And what sort of places?
Sorry, but I didn't hear that.
Were they referred? When you say that...
Primarily into the CRIS service, who then would manage them out. So primarily into the CRIS service. Around reviews and involvement and engagement, so we have one of our other directors, not Maria and I or Alison, but one of our other directors who is a member of the Staffordshire and Stoke-on-Trent Urgent Care Board, where some of the things that you're discussing will no doubt be discussed there for decisions and content. So we don't participate, but we know one of our other directors does. So we are represented in there and we'll be able to contribute in that meeting as such. Then Alison, if you wouldn't mind just picking up on the wheelchair point, please.
Yes, I mean, just to pick on the rest on the urgent care. So I think the other important thing is that when our paramedics arrive on scene, once they've done a holistic assessment of the patient, if they think the patient can be managed in the community, they will have a direct conversation, usually with Chris, who will then decide which the best option is with the paramedic in terms of which community service might be available to come and support them, or if in fact the patient still needs to go to hospital for some reason. So we have good clinical conversations. So our paramedics are kind of facilitating urgent care as well as emergency care for many of these patients. In terms of the wheelchair, everything that is put in an ambulance has to be signed off at a national level to be suitable the way it is restrained to be crash tested. So ambulances are crash tested with the defibrillators in, with all the clinical equipment that we have in. Now, it's impossible to have a crash test system that incorporates every kind of wheelchair, because some people have got incredibly, as you say, some incredibly specialist wheelchairs. And what I would expect from an emergency department point of view was we would always transport somebody who used a wheelchair. The question is whether we would be able to take their wheelchair, which usually we can't. But I would expect that through the emergency department systems linked into our OT and physio systems, that either a similar model could be provided for the patient while they were in hospital with their own wheelchair available at home, or a discussion had between the hospital and the family with a mechanism to pick up that wheelchair if it needed to be moved, because equipment is moved around the region and different sub-regions the whole time for patient benefit. So that should be possible to be achieved. And I don't know about the individual case, but in theory that should be achievable. And certainly one of our paramedics had a conversation with me when something very similar happened, where her mother needed a very specialist wheelchair. And in fact, we had to get one from outside a region. She had to get one. It wasn't me that did it. She had to get the services, the OT services and physio services, to coordinate the movement of a wheelchair from outside the region for her mother. So it can be done. There was another part to the question.
It can be done, but if someone is then without the wheelchair for several days, because I know how long it can take to source these things, it means that you're discriminating against people with severe disabilities. And it also means that therefore, when they're in hospital, if they're without the wheelchair, they are effectively trapped, imprisoned, in fact, in the hospital. And it's something which has to be addressed, because it should be possible, just as it is in a domestic vehicle, like a Mercedes Sprinter van, for instance, to ensure that you have restraints within the vehicle, which means that the wheelchair is safely transported with the patient. And it's a real concern, and it does actually mean that people stay in hospital for much longer than they need to because they can't actually get out.
Yeah, so I completely appreciate what you're saying. The issue is that we have a responsibility to. So normally a wheelchair is put in the boot of a vehicle or in the back of a vehicle, isn't it, behind the seats? But we've got responsibility to everyone in that open area in the back of an ambulance that if there is a crash for any reason and that wheelchair is not restrained fully, and some of these are quite big and heavy, that there is a risk to the occupants in the back of the vehicle, including the patient, if the wheelchair becomes loose and flies across the area. And the reality is that nationally, the ambulances are not made to restrain every type of wheelchair or other aids that people might need in hospital, but there are supposed to be systems in place for either the hospitals to provide them, and obviously they have got their own wheelchairs because that's how they get patients round most of the time in hospitals. I appreciate they're not necessarily fully facilitated for individual patients, but our number one priority is the safety of patients and staff.
We're coming to our conclusion shortly. Councillor John Jones, and then I will sum it.
Thank you, Chair. I'll be very quick. I just wanted to back up Councillor Jessel's request for the data on the rural postcodes. But I know what it's going to say because we've had that data from you before, and it proved that the rural areas are suffering compared to the urban areas. But what I wanted to ask was, could you make sure that when that data is provided, it's provided in a readable and interpretable form? Because the last time, as was alluded to earlier on, we had a big spreadsheet like this, and it took about a fortnight using a retired senior manager from the WEMAS, Lee Washington, I'll name him, he won't mind, to sort out what we needed to know. So I just wanted to make sure if we can have it, it'd be nice to see what the current situation is, because there is no doubt it's better than it was. But just that we can have it in a form that we can understand. And I can't resist this, Murray. At one point in one of your earlier answers, you said if an ambulance clears in a rural area, it's then available for another rural call. If it clears at Stoke, it's not. I think you've just made the case for putting rural standby points back into the moorlands. Thank you. Thank you, Chair.
Mr. McGregor.
I wish it were as simple as that, John, and both of us know that that's simply not the case. So let's knock that one on the head, shall we? So rural areas, I've sent September's data up till yesterday to Zach just now. It is the data that we are asked to provide. Very happy to try and explain it to Zach if he wants to pass it on. That's what we're asked to produce nationally, so that's what we've given you. It gives you the number of jobs by each postcode area, so ST1, for example, by category 1, 2, 3 and 4, the number of cases, the mean and the 90th centile, so the mean being roughly half, how long it takes to get half the jobs, 90th centile, how long it takes us to get to 90% of those cases. Those are the metrics that we're asked to provide data on nationally, so that's what we've provided to you. I'm very happy to give you some time, John, if you would like to go through it in detail.
If we could just have what we want to see extracted, Murray. Just compare it with an ST1 with an ST13 or an ST8. I don't know what postcode you want.
Well, it's all the postcodes in Staffordshire. It's every postcode in Staffordshire.
Yeah.
I can't, we've broken it down as much as we can break it down. I would just repeat that we're not funded by postcode. And if you want to fund it by postcode, there is a very considerable cost involved in that.
That's the main part of the problem, really, isn't it?
Well, I wouldn't disagree. And we're very happy if you want to give us an awful lot more money to provide you a lot more cases. So, yeah, rural areas, there is no question that our performance in rural areas is not good enough. We will be the first people to say that. However, if you look at the level of delays that we have today as opposed to 2019, they are chalk and cheese, and that explains why the difference in performance is the way it is. There is a direct correlation. Even NHS England have now agreed that there is a direct correlation between the amount of time we spend outside hospitals and how quickly we get to patients. I mean, it's logic. If you're stuck outside a hospital, you can't be with a patient. And so there is a direct correlation. But no, I'm sorry, you'll never get me to agree on the rural standby points.
Okay. Thank you, Mr. McGregor. I would obviously thank you for your time, and I think we've given this a real scrutiny session on it. I think from my point of view, I think you've got the message. We represent, certainly within the Staffordshire County, excluding, say, Stoke-on-Trent, we represent a rural county. And our concerns clearly are based on that kind of service of what can be given. So obviously you acknowledge that, and I think what we would like to see is some further improvements on the service, acknowledging obviously there has been improvement, but I think there's still room for further improvement, and we can all agree on that. I just wanted to pick up on the points that were raised in terms of providing the data. So we have received Murray's, which we will share immediately after this meeting. And obviously, if there is anything members wish to come back on that, Zach and myself will take that forward to the Vivek and Murray and Alison. So that will be very much helpful. On the exchange of good practice, we will follow that up. I know that Alison has acknowledged that, but I think it's important if that's the will of the committee. And also to write to the ICB with regard to Chris. Our committee happy that those recommendations go forward. Yeah, I'm getting nods and hand acknowledgements. So I think that might cover it. I don't think I've missed anything out. So again, thank you, Vivek and Murray and Alison, for your attendance. I think it would be probably right to say that we're not going to let this one go, and we will very much require another session as the work programme goes over the next 12 months. I think it's key that we must ask these questions to represent our rural communities. Okay, thank you. Vivek, do you want to just come in?
Yeah, just one thing that we would appreciate a bit of help with, actually, Chair. So I think in November we talked about an independent capacity review, and we've made a formal request for such. Now, what would help us is if the committee would endorse the need to have one, because what we said, and when we've made this request ourselves, is we want to see an independent review of us as a region, us at an ICB level, and then as close to being as a postcode as possible. That will then start to paint the picture of what would it take to give the kind of response times that people would seek. That would put some pounds and pennies and numbers to the problem. So we would appreciate it if the committee would endorse the need for that to take place, because that's a request we've made of our lead commissioner. I don't think anybody here would disagree with that need as well, if that's okay.
Thank you very much for that. And
yeah, we raised it there as well, I think.
yeah, we had that endorsement on the 13th of November, so we will take that up and refresh that to ensure it happens. So thank you very much for coming to the chamber, and you're quite welcome to stay on for the next item. I would appreciate.
We need to stay for the we thought we needed to stay for the DFIB report. Yeah.
Okay. So let me just get back onto my laptop. Thank you. Okay, moving on then to item 5, the defibrillators inquiry day at WMSS at NHS Stafford Hub. This is a report to the committee by myself. Members, you have before you the report following the outcomes of that visit. I felt that we had covered quite a lot from what our concerns would be with DFIBs and how the ambulance service reacts and knows how to put it all together. And I think it was certainly the system that we saw. I personally believed, after looking at it, that that everything there is possible to ensure how the DFIBs are, those that are registered, are picked up on their system, and the nearest one will be acknowledged on the phone call and such. So that all the findings are within the report. I'm happy to take questions on that. Then we go into our on the British Heart Foundation. We were hoping that they were going to be here today, so possibly their presentation would have taken probably a good chunk of the meeting. So what's happening is that they will provide us, that we request then a briefing note to highlight the public awareness campaigns and information in relation to the remit and the responsibility of the Guardian's stakeholders and the long-term implications of DFIB's ownership, maintenance and associated procedures. I think it was clear what we got from the visit, that those maintained DFIBs are the ones that are clearly registered, and those are the ones that are highlighted. So it's important to know that. Councillor Norman.
Yeah, just to ask a question on this, but before I do, just wonder if you wanted to congratulate me on not asking the question about those videos I've seen where the patient's dog is running after the ambulance and is allowed on the ambulance. It's probably abroad, isn't it? You've not seen those videos, I'll send them to you. But, compared to the wheelchairs, I thought that was the more interesting aspect of it. My only question was about this report. It's a good report. I appreciate that. And the recommendations are that it goes to the district and borough overview and scrutiny committees, and certainly one on the task group that we're actually setting up at Lichfield District. But I just wondered what you wanted us to do with that. What was the best way? If it comes to our district, I mean, apart from the information it contains there in that, what specifically would you like the district boroughs to do with that? And you might even say at the meeting, but I'm asking you now.
It's a good question. I think what we really want to come out of the whole exercise is that awareness. So obviously, in terms of can the district and boroughs bring something in terms of doing something within their own areas to awareness. So we're ensuring that if we can ask for assistance, I think is the word, to make sure that awareness of DFIBs, it's not about just getting a DFIB, putting it on the wall and then forgetting about it. There's actually a real essence that it needs to be maintained, registered. Obviously, if there's a situation where it has been used, the West Midlands do know that that will be out of action, and then it gets, once the battery is replaced or whatever is replaced within it, then it then goes back on the system as a live operating DFIB, but it won't be live until all that has gone through. So it really is, Councillor Norman, is asking for the district and boroughs to raise awareness within their parishes as well, that we can make sure that we're covered. And it's something that I think within the report we're also asking the Cabinet member to also raise that awareness so that we're all talking the same language. I've got quite a few hands go up there, so I'm going to try and take them as in order as I saw them. Councillor Charlotte Atkins.
To say that Stafford Waller's District Council have agreed to maintain the defibs within our patch for the next 2 years to try and sort out the mess that was left. So that the new administration, very much led by my colleague Lynn Swindlehurst, working with AED Donate to make sure that we know where they are, that they're properly maintained, that when they're used, you know, they're dealt with, and so on. Because what was happening was that they weren't on the system, that there wasn't a system in place to ensure that those defibs were properly maintained. And so what the council has done is to pay for 2 years maintenance, during which time we would look to ensure that there should be some community partnership to ensure that those defibs in particular villages or elsewhere were properly looked after with clear lines of responsibility, so that we don't get the situation which we got in Ipston's, where the ambulance service didn't recognise the defib. So that, I think, is an important initiative, and hopefully other councils will follow our lead.
Thank you very much, Councillor Atkins. That is a clear endorsement of what we're trying to come through, and if that, again, good practice can be shared, that's all good. I've got quite a few wanting to speak, so Councillor Sylvester Hall.
Thank you, Chair. I attended this day and this inquiry day, and I thought it was so informative with regards to the history of how Guardians had, with the best of intentions, installed defibs in various parts, but making sure that that information was contained on the circuit, and the importance of keeping that information up to date. So if there is that call that's received by the centre, they can look straight away what proximity the nearest defib is and how it can be accessed, and then the maintenance of it. And that is such an important piece of information that I took out of that visit, that for me, that's what we need to be making sure that our district, boroughs and parishes are given that same information. And equally, the role of the British Heart Foundation. So it is unfortunate that they can't be here today to be able to pass on their role and what they can do in making sure that all of that information is centrally co-located, so that when we need it, and in the event that that information is required, that it's there at the fingertips and it's accurate to be able to do that. So I would equally endorse what their role is and how that central source database is pivotal to making sure this is an effective implementation.
Thank you. Murray, you indicated you'd like to just come in on that.
Yeah, if you wouldn't mind, thank you. I realise I'm not a councillor, but I hope it's helpful. I know in the villages I live in, there are 3 defibs. I checked where the nearest ones were to me for fairly obvious reasons. However, whilst out and about in the village, I found one that I hadn't spotted before, and so checked on the system to find out if it was there, and it's not registered. And so it was on the wall of a shop. So I actually went into the shop to say, your defib isn't actually registered, the ambulance service won't be able to send it, and they were fairly shocked by that. So all I would ask is of your good officers is to look for the defibs, or find your friends and ask them to check whether the defibs are on the system. You can check, it's very simple. British Heart Foundation have got an app or a website, defibfinder.uk. You can check and see whether the defib is on there. We know that within the West Midlands there are about 3,500 defibs that are not registered, which is tragic, quite frankly, that people have spent £1,000 getting a defib and we aren't able to send somebody to go and get it. Now, some of those are in the likes of doctor surgeries, curiously, or dentists and places like that. But the fact that we know that there are roughly that number, there may well be more that are not on the system. You know, as many of you said, you know your communities very well. I would really ask you to go and check and see whether the ones in your local communities are there. As I say, it's dfibfinder.uk, and you can check out where the nearest one is to your own house, if you don't already know.
Thank you, Mary. It was something that probably just before bringing in Councillor Hood, my thoughts are that may, and I saw a news release that there's a defibrillator now installed in the Lichfield Cathedral. And it begs then the question, when the cathedral is locked, and it's the same applies with those defibs that are within schools, that may be in the school compound that is locked. Could you just, how would you manage that process, looking on your system live, what is available?
So, so the circuit, I'm sure you'll get I'm sure you'll get a hotline for that comment. Whether to up or down, perhaps we'll leave to another day. So the circuit will say whether it is available 24/7 or not. The government did put in, the previous government, sorry to any Labour colleagues here, did put funding available to schools to put defibs on the outside of their buildings, because we know in the case that Alison mentioned earlier, they did try and they knew of a defib at a school, but it was locked inside and was not available. So there is a real push. And we also know that roughly 60% of cardiac arrests out of hospital happen within a very short distance of schools. It's a curious statistic, but a huge number of cardiac arrests do happen very close to schools, generally because schools are in the heart of their community. So yes, it is something that we would always ask for a defib to be available 24/7, but the circuit will capture that information.
Thank you very much. Councillor Hood.
Thank you, Chairman. Really leading on to what my colleagues have been saying, my concern is the fact that we have certain people going around looking where there is a lack of a defibrillator and then presenting themselves as an official on defibrillators and virtually selling them to that organisation. I've recently had a care home speak to me, and I was absolutely shocked at what was being said to them, but they are naive in the fact that they think that everyone that sells a defibrillator has probably come from the British Heart Foundation. So I think as county, district and parishes, we need to get that word out there. Just be careful, you know, and selective as to who you invite into your association to provide that defibrillator. Thank you, Chairman.
Thank you, Councillor. That's a very, very important issue, because it can easily be missold and therefore misrepresented. Councillor John Jones.
Oh, thank you, Chair. I'll be quick. Councillor Atkins said pretty much everything I was going to say about what's going on in SMDC, but I just wanted to pick up what you said, Murray, about dfibfinder.uk or whatever it's called. The important database is the circuit, not that one. And defibs...
They're the same, John.
They're not. I'm sorry, but they're not. I speak as a guardian of 22 defibrillators in my area, and half of them aren't on dfibfinder.co.uk. They're all on the circuit, and they work quite well. The dfibfinder.co.uk doesn't correlate directly with the circuit as far as I'm aware, and certainly, as I say, half of the ones in Biddulph are not on dfibfinder.uk, but they're on the circuit, and they work very well. So I think one of us or both of us needs to check that.
Mary?
Well, defib finders run by the British Heart Foundation, so you know, if they haven't transferred the data from one to the other. If I can try and be a little more helpful, I think it's worth bearing in mind about the number of defibs in the area that we are. And Chair, you'll have heard while you were at the control room that when we get a call to a cardiac arrest, the system will automatically look for a defib up to 500 metres away from where that incident is. Now, 500 metres is actually not terribly far, but research would say that's about as far as people can run to get it and bring it back in a reasonable amount of time. So all I would say is, yes, your village may have 2 or 3 defibs, but you want a defib to be roughly every 500 metres or thereabouts. So the number of defibs that there are in this country is still very small compared to... I'm sorry, do you want... Okay, I'm trying to be helpful here. If you look at somewhere like Denmark, where the survival rate for an out-of-hospital cardiac arrest is 20 to 25%, in this country it's 7%. Now, I think it's quite important to talk about defibs and how important they are. You may disagree, sir. But I think, you know, the realistic thing is we need many more defibs if we want to save more lives.
Thank you very much. Councillor Atkins.
Thank you. Yeah, I represent a very rural division, and I've sat and listened, and I go to my parish councils, and I was picking up on something that Jill Hood was talking about, that everybody wants defibs in their area, and I do fully understand the 500 metre thing. Some of my villages have fundraised and got 4 defibs in them, and some haven't. Some have taken it on, and they probably, if they tried to do the 500 metre, I'm sorry, they probably need about 500 because they're so sparsely populated. But they've done the best that they can. But what I'm picking up now is, and it's picking up from something that Charlotte Atkins was talking about, is it's all very well, and everybody's very keen to buy them and put them in place, and then there's the maintenance that crops up. And the parish councils are picking that up, and they're finding that their precepts are quite small, and they're now taking on the responsibility of funding this with the guardians that they have and everything else. So there is something, and I don't decry the efforts they're making and the way that they're doing it, but there is something about being open and honest about, yes, they're a good thing, but you are taking on a responsibility as a guardian and as a continuing maintenance. I've always said this about councils. Everybody wants the new whatever it is, but forgets about maintaining the building or whatever it is over the next 20, 25, 40 years or whatever it is, and making allowance for that, rather than the succeeding people then have to pick up the problem of how they continue the funding of something that is really good. So, you know, I fully understand the you need help within so many minutes if you're having a heart attack. I've lost too many friends who've been out in the rural areas, and sadly nobody's been able to get to them within 18 minutes.
Okay. I think if there's anything else on that, we can share that directly with me if you wish. I think from the outcome of our discussion there, we're going to request the... Yes, sorry, Councillor.
Can I add one thing as well? You may not... Nobody talks to rural that very well, but we had the first community first responder, and at the moment I think I've got about 4 community first responders in the area who probably, I hope they carry something along those lines in their vehicles. So there are other ways of attacking it rather than fixed positions.
Thanks for that, and I do know that some road police unit vehicles now have them within their capacity. So as a committee then, we're going to request the British Heart Foundation provide us with that briefing. I think that will be helpful to ensure that perhaps the concerns that Councillor Hood and Councillor Atkins have just raised regarding those prospective sellers, and then real people realising that not really taking the responsibilities to what they have to do. So I think that's the awareness that we're going to ask the parishes and the districts, boroughs, and the British Heart Foundation. Are you content with that, members, that we carry with that? Okay. So thank you very much, and thank you again, Vivek and Murray. Alison's already left us, so that's fine. But thank you very much for your contributions, and it is appreciated. I know it seems that we can give a rough ride, but that's the role of scrutiny at times. But I'm hoping that you'll find that we've been fine with it, and apologise if there's any feel that we've overstepped our remit. But thank you very much for attending.
No, we're very, very happy to come, and I'm sure we'll be back in the not too distant future.
Yes. We will. Thank you very much. Thank you. So, moving on to item 6 on our agenda, the Director of Public Health Annual Report. And I can see Richard Harling at the back there, our Public Health Director, and being accompanied by Councillor Paul Northcote, Cabinet Support Member for Health and Care. Would you like to present your report? Thank you.
Thank you, Chair. So the theme of this year's Director of Public Health Annual Report is the ageing population. So the population in England and, of course, in Staffordshire is ageing, and it's ageing pretty quickly, actually. Since the turn of the millennium, the number of people over 85 has pretty much doubled, and over the next 20 years, it's going to about double again. And meanwhile, over that entire 40-year period, the number of working-age adults will remain more or less the same. And that means that the ratio of working-age adults to retirement-age adults will gradually reduce. Oh, I've been cut off. Shall I continue, Chair? That, I believe, will have some quite profound consequences for society, for public services, and especially for health and care services. So looking at health and care services in particular, age is the main variable that drives demand. The report includes a few calculations that they are pretty broad brush, back of the envelope type calculations to try and estimate the additional costs and the additional staffing requirements that we might expect from that ageing population over the next 20 years. And I've come up with figures in the order of £600 million additional and about 20,000 additional staff for health and care services. So those are quite big numbers, and it isn't immediately obvious to me where either the money or the people are going to come from. So we've got a new government that is signalling an ongoing financial challenge for public services, and of course the number of people in the workforce is not going to rise. So there's not going to be many additional people to work in any sector actually, let alone health and care. There is therefore, I believe, a risk that health and care services either run out of staff or run out of money, or both. The report suggests 3 ways that we might mitigate that risk. The first one is a real focus on prevention to increase healthy life expectancy and reduce the number of people requiring health and care services as they become elderly, and especially towards the end of life. The second one is to rethink the way we care for the very elderly and frail at the end of life and focus much more on dignity and compassion rather than on extending life. And the third one is to continue to explore ways that technology might complement the health and care workforce and just free up that bit of staff time. The report then goes on to make 7 recommendations, which I won't read out. I do hope that the report might become a resource for this committee just to help you raise questions with health and care services, with the council and others. So those questions might include things like, What else might the county council, the district and borough councils, the public businesses do to try and adapt society and the environment to an ageing population? You might want to ask about the amount of funding available to the NHS and adult social care and whether that's rising commensurately with the ageing population. You might want to come back and look at the number of staff in health and care and think about whether that is rising in line with demographic change. You might want to ask questions about the progress on prevention and whether the health and care system has a coherent delivery plan for managing frailty and end of life. And finally, you might want to explore at future sessions whether we're really maximising those benefits from technology. So I don't think I can give you all of the answers to those things today, but hopefully there's a bit of data in the report that might help you in your future work. Thank you.
Okay, thank you very much. Councillor Norman.
Thank you, Chair. It was in this very room and other rooms in the county buildings at the turn of the millennium for having these self-same reports, because we knew the ageing population. We could see that the trajectory of that, and as you say, there's no increase in the workforce to pay for that. So this isn't new, but it is quite dramatic on some of the figures there, particularly on page 5. I think it was page 7. No, page 5. No, page 7. The dramatic figures that are outlined in the report here, which I'm grateful. Just to say on page 5, on the 5 tips, I do 3 out of 5, so I'm getting there. My interest in the proactive and compassionate side of things, which is referred to in the report and what we can do. So I used to work for Age UK South Staffordshire as a Senior Information Advice Officer, later Age UK Staffordshire, but what astonished me was that the funding for Age UK, which deals with older people, was cut by the county council, and I don't think it's ever been restored. What we could do is actually help those older people in their homes, have volunteers, help them fill in attendance allowance. They could actually be £140 a week better off. That would keep them out of hospital a bit longer. There's other stuff that you could do for them. And it's always been astonishing that that's never been continued, that support for Age UK. All of the similar charities could do that. I mean, because I worked for Age UK, because I knew what the rules were, when I needed to get my father over from Warwickshire, just over the border into a nursing home in Staffordshire, I wrote to the Director of Social Care at Warwickshire County Council, copying in the national lead on the LGA, who happened to be the leader of the County Council, and I got an immediate call back with a personal telephone number, which I did not want. I just wanted to say, these are the rules. I know what the rules are. My father needs to go here. Now, I had that information and knowledge, and others will not have that, and won't have that support from a charity. So my question is simple. Since the recommendation's there, and I support all of those, I've always supported the issue with age for obvious reasons, having worked in there and understanding the problems. But do you not think that we could actually support, the county council, can support older people by supporting charities like Age UK, Staffordshire and other similar organisations for getting benefit increases as well as those other care needs that they can do in partnership with the county and the NHS? Thanks. Oh, it's a political question. Again, you don't need to answer my political questions, you know.
So, I think the whole range of voluntary sector and charities play a huge role in how we help people age with dignity and how we help them to end their lives in a place of their choosing. I think the actual question about whether the council prioritises additional funding for those sorts of charities over something else I think that's a question for another day, and that will be something for the MTFS and something that I suspect you'll get the opportunity to debate in the full council chamber. Just coming back to concur with your point, I do worry that far too many very elderly and frail people continue to be admitted to hospital right at the end of their life, and I am very concerned about the level of distress and indignity that causes. I see a lot of really good examples about things that are being done to try and avoid those sort of circumstances. Unfortunately, the numbers are going up and not down. So the real question, I think, for all of us is whether we yet have a systematic approach right across the NHS and local authorities that's really going to help people as they get to their very advanced years to sort of end their days in a way that I think we would all want to.
Okay, thank you. Can I call Julia Jessel, please?
Thank you very much, Chairman, and thank you very much, Richard, for that report. I can remember some 50 years ago listening to Professor Chris Ham making some very similar predictions, and I think then it was predicted that by about 2030, this country, in its current models of care, would need about a third of the working population being involved in health and social care. And as we all know, that's unsustainable, both in terms of numbers and finance, and your report clearly outlines the basis for that. So things haven't changed. We've known, as baby boomers like myself, we've known for a long time, since 1950, that we're going to cause a bit of a problem. But that actually the falling birth rate is exacerbating that problem. It's been mitigated by perhaps the inward migration of people who have helped to balance that ageing younger population. But it is a problem that we've had. And I think there's two problems. There's the here and now. There are a lot of elderly people, and I totally agree with everything you've said, particularly in how we deal with what I'll call the ethical problems of how we deal with very frail elderly people. You know, I've got friends, I've got relatives who are not where they would want to be, nor where I would want to be. It frightens me dying very slowly and in an undignified manner with Alzheimer's or whatever. It's not what any of us would want to see. But that's where we are now. I think the one thing that your report perhaps misses is there's the next tranche coming up. There's the 40, 50, 60-year-olds that we've got to get the message through that, A, your health is your responsibility. And I often like to people watch, and I think people watching at an airport is quite an entertaining but an educational experience. When you see the proportion of people who are drinking too much alcohol, who are most of them grossly overweight, and you think we are not getting that public health message through to the general population. And that's one of the questions I would ask is, with all the work that we're doing to help people with weight management live a more healthy, active lifestyle, whether you feel that actually that is delivering what we want in the quantity that we need. The other thing is, and being a very practical sort of individual, I think as a society, we're frightened to talk about death. People don't talk to their friends and families about how what happens when I die, what service do I want, what hymns I may or may not want. But equally, there's things like people don't want to talk about doing a living will, which actually gives you a little bit more control over what happens to you as and when perhaps your mental capacity may not be quite what it should be. And I think we need to educate the population as to it's your responsibility. You can't just, while you're able to do these things, whether it's lasting powers of attorney, living wills, you need to prepare for what is inevitable. We're all going to die, and we'd all like to die pain-free and with dignity. Most people will not talk about it, so I think we need to have an educational drive, particularly of that middle-aged group, so that the problem we've got now actually isn't made worse and worse, which is what's being predicted in your report. So in terms of what we can do, I think we can raise that awareness. I think the other thing is, and again your report highlights it, we can't carry on doing the same and expecting the different outcome. And we can't afford, either through people or finance, just to keep doing more of the same and expecting a different outcome. And I think technology has some of those answers, but particularly within adult social care, the private sector, they are not always terribly quick to pick up on what's available. And I think as an authority, we have huge purchasing power. We need to use that to ensure that within that adult social care system, that actually the providers are maximising the benefit both for the people that they look after and the people who are paying for that service, so that actually we get a better quality service but at a more affordable price, and actually in doing that make it far more efficient in terms of the manpower that's used. Thank you.
Thank you, Councillor Jessel. Do we want to come back on any of those points, Richard or Paul?
Just that both the questions so far have are quite right. That this is not a new revelation. This is something we've known about for years and decades. But it's something I don't think we really talk about enough. So one of the aims of writing the report on this theme this year is just to do exactly that, to try and stimulate a bit of debate and a bit of thinking about it. There was a bit in that question about prevention and lifestyles and whether we're really seeing a turnaround there. Are we, the council, doing things which positively influence people's lifestyles? Yes. On a macro scale, is that having a significant effect on the way that people lead their lives in terms of how much they drink, their weight and that? I think the jury is still out on that one. So I think we do have a lot of work to do there. One thing that does hearten me somewhat is that the generation coming through behind mine do appear to have a much healthier relationship with things like alcohol than perhaps my generation did at their same age. So it may be that we're seeing a sort of bulge move through, just as the smoking epidemic moved through the population, sort of taking off in the 1920s and is now dying down. We may see the sort of obesity epidemic sort of dying down over the next 20 to 50 years. The problem is whether that happens quickly enough in light of the rate that the population is aging at the moment.
The other point I made is about living wills, lasting power of attorney, whether you feel as an authority we could have any role in publicising the benefits of doing things like that, making preparations for what is your inevitable death. Not just yours, ours. I'm not just pointing a finger at you, Richard.
So I think we have a leadership role there, so we can't write people's wills for them, but we can help people to understand that there are a whole range of things that they can do before they get to that very elderly stage, which will make the end of their lives much better. So lasting power of attorney, living wills, end-of-life care plans. Are we doing enough just at the moment? Perhaps not. So I think we could perhaps do more there to try and raise awareness with people about all of those opportunities and what they can do. And perhaps this report will help to engender some of that action.
Thank you, Richard. We do have on the very the bottom of our work programme items for future scrutiny, which does have an item there for perhaps a working group to look at in terms of end of life and compassionate communities. So perhaps we could encompass those concerns into that, but we'll come to that later. So on my list, Charlotte Atkins.
Thank you very much. I have to say that my husband died at home, but the main obstacle was actually getting carers allocated so that he could actually die at home. That was the key issue some years ago. In terms of prevention, you know, that's one of the three elements that you identify in your recommendations. I remember, long before your time, Richard, that the County Council came up with an amazing, fantastic prevention discussion called the Big Fat Chat. They decided to have public meetings entitled Big Fat Chat. I don't know what 20-year-old came up with that ludicrous slogan, but it clearly was not going to be a very helpful or encouraging slogan to ask people who were perhaps a bit overweight to get involved. And then people seemed a little bit surprised when I thought that this was perhaps not a very helpful initiative. One thing that was helpful was commissioning Everyone Health. But the trouble is, it was tiny, absolutely tiny. I decided to put myself through this programme. I did have to add a few stone onto my weight to qualify, and then, you know, I've turned up and went through the various exercises. And in general, it was good. It was good chair exercise, you know, good coordination, some quite useful stuff around healthy eating and so on. But it doesn't touch the sides, because the people who go to that are the people who are already thinking about healthy lifestyles. And to pick up Councillor Jessel's point about, you know, we have to take responsibility for our health. Well, if you live in an environment with 20 takeaways and no greengrocers, then it's a little bit more difficult to think about your health, isn't it? You know, that is the point, that not everyone has those choices. You know, you might say, okay, you know, calories in, calories out, but it is very much more difficult for some people in some communities to live a healthy lifestyle. And we have to take that on board. And I don't know how we do it, but at the moment, as a public health authority, we are not going anywhere near the need of populations that are struggling with weight management. And, you know, our hospitals are full of people who require bariatric surgery because it's considered to be a cheaper option than to allow them to continue with their excess weight, because that leads to all sorts of other health problems which would be much more expensive to the NHS. So it seems to me that we have to work much more closely, obviously, with community organisations, as Councillor Norman was saying, to make sure that we do have more active lifestyles. But certainly the case is that we expect voluntary organisations to do the work, but we expect them to do it with no funding. And any community organisation has to have funding just to cover basic overheads. And prevention has never had the priority that it should have. And, you know, we talk a lot about, you know, the impact on the NHS of not having social care, but the impact on the NHS of not having proper prevention strategies is really a key concern. Clearly, it has to be addressed at a very early stage within schools. It shouldn't, you know, the Labour government introduced free fruit and veg, you know, for youngsters in schools to introduce kids to eating fresh fruit and veg, which might not be bought at home because people buy stuff which they know their children will eat. You know, those sorts of initiatives are really important if we're going to get a healthy population. You know, by the stage someone is massively obese, then that really is at a point at which there's very little that can be done, except perhaps surgery and such things. But I do think that we, as a public health authority, go nowhere near the sort of initiatives that we need to do, because we just don't get to the populations that we need, whether it be smoking, whether it be unhealthy eating, or whether it be lack of exercise.
Richard, would you like to come back on?
Thank you, Chair. So I think the thrust of that question was about our approach to trying to prevent obesity and overweight. I agree that Everyone Health do offer a good service, and the outcomes for that are pretty favourable. We are never going to address the kind of obesity challenge with an individual weight management intervention. The numbers are just too great. If you think at Staffordshire, something like 2/3 of the adult population is overweight or obese. That's somewhere in the order of 500,000 people. You know, we're never going to have a weight management service that can deal with those sorts of numbers. Our focus on the moment is much more about the broader societal and environmental determinants, so things like fast food takeaways, availability of fresh fruit and vegetables, transport and planning policy that encourage healthy transport alternatives, all of those sorts of things. I think ultimately that will be the way that we make a difference. Unfortunately, it's not going to be quick. And it's not going to be the sort of thing where it is easy to say there's an intervention which we've completed and there's an outcome that's resulted, because it's a complex problem that's multifactorial. I do think it's the right approach. Be very happy to share more about that with the committee in the future.
Okay, thank you. Councillor Edgeler.
Thank you very much, Chairman, and thank you for your report, Richard. Yeah, I mean, it's a shame, isn't it? We can't go back to the 1950s when doctors used to visit all the elderly who were under a certain age, you know, and looking after them and stopping having, going to care and what have you. My concern at the moment is the impact on the really elderly that are living on their own, and that the impact of this winter fuel allowance, if that's not reinstated, and the impact it's going to have on our elderly and their health is really, really frightening. And as a county councillor, I really don't know what we can do to eliminate that. But, you know, it's going to be on us before we realise it. And I'm really worried about the elderly that's on their own.
I'm not sure I've got much in the way of response to that. So, I mean, it's a decision by central government, the winter fuel allowance. There may be a question for us as a local authority about to what extent it might be possible for us to mitigate any impact should they arise. But again, that's probably a question for another day.
Thank you. I've got Councillor Jill Hood.
Thank you, Chairman. I wasn't going to talk on obesity, but feel that I must with 4 daughters. I don't think there's a night goes by when they're at home that I don't have someone knocking on my door delivering a takeout. And I haven't heard them order the takeout, but it is so easy. They all have apps. They have special offers that come over. We've got television programmes, advertising, Domino's tonight, you know, get 4 pizzas for half price. It's just absolutely crazy. And, of course, I have to clear up after all of them. Don't have to, but it will be left there for days if I don't. I have a 9-year-old grandson that I look after, and he's just started middle school. And can you believe that his middle school absolutely doesn't, Granny, serve vegetables, only beans? So I know damn well that that school serves vegetables, but how can we get the message over to the school that they need to encourage these children to try the vegetables that are there? He has to eat them at home, so he should be made to eat them in school. And it's very, very difficult, but I absolutely believe that our education system is the key to some of the obesity problem. I mean, a lot of people get great comfort out of eating, but when I look at some of the young people, they are huge. And surely, you know, we can do something now, early intervention, to help them so that their problems don't carry on into their later life. But I agree with you, Richard, that the generation now that are up and coming, particularly the 30 to 40-year-olds, alcohol consumption is going down. Takeout consumption is going down. We see them boasting about their gym membership, and this is really encouraging for our future, very, very encouraging. But what I did take from this report, which deeply disturbs me, I too will share a number of years ago in the full county council meeting, Alan White telling us about a seminar that he'd been to and how a vacuum cleaner-like appliance would whiz round care homes. It was called artificial intelligence, and it would deliver some of the care that was given in care homes. This absolutely terrifies me. I chair Age Concern Stone District. I used to be an Age UK trustee, but then realised that they charge for most of the service and advice that they give. So moved over to Age Concern Stone District, where everything that's done is free. And we help a lot of extremely elderly people well into their 90s. And one of the things that really, really worries me is that when I can only speak personally, but I know I've shared this with my age concern, when I take them to the doctors and say they're having a dressing done or they're having a vaccination, they'll chat. The staff are absolutely wonderful. I attend 3 GP services which are within Stone that my residents use, and they'll say, well, can you come back in such and such? And they'll say, well, I can't because I'm housebound. And immediately the retort is, you're not housebound, you're transport bound. I haven't found anything in this report that mentions the difficulties of transport. But for an elderly person to get from their home to a doctor's surgery by taxi, you're talking £10, £12 and then £10, £12 back. We've mentioned the loss of the winter fuel allowance. That's a big chunk that's going to be cut out of their income. The cost of living, it's huge. Energy prices, it's huge. It's a massive drain on what's coming into their household. And I really am concerned about how they're affording to do all these things. But transport in most of the areas, particularly rural areas, are crucial to them. We can't supply enough volunteers to take our elderly to doctor's appointments, to pharmacies. So I would like to see this county council sort of stumping up with a transport, a much better transport plan than we've got at the moment, because we do have a fast ageing population, and I really, really worry for them, because as I say, volunteers are scarce these days. But thank you for your report.
Richard?
Thank you, Chair. So, on the technology point, I think it is very unlikely that care by human beings is going to be completely replaced by machines within the foreseeable future. I think there is, however, potentially a huge role for technology to complement the role of people, and we already see that. So if you take some examples in home care, most home care companies will use a GPS-based app which minimises transport times. So you make the best use of staff time by minimising the time they're in the car and maximising the time with individuals. That's a really good example of technology adding value. In some care homes and supported living type schemes, they're looking at using remote monitoring of people just to reduce the level of intrusion by staff having to go into their rooms all the time. So again, I think there is a huge potential there, and there may be even more potential as technology is developed. If we are trying those sorts of things as a council, we do roll them out sort of responsibly. So we pilot things, we see if they work, we see if they're acceptable to people, and only if all of those kind of tests are demonstrated do we look to roll it out at scale. Second bit of your question was about transport. And I think that's an example of a really good question for this committee. So if transport for older people is a problem now, it's likely to be more of a problem in 20 years' time, isn't it? So the question is, okay, what is our role, if any, in mitigating that and trying to help people get about their community?
Thank you. Baz, do you want to come in on that? And then I'll ask Sylvester Hall to come in.
Well, it was going to come up in a particular way, but just to mention, just on this point of transport, having spoken to PPG groups, especially across the moorlands, some of their concerns were exactly as been said here. And what they're saying is that for them, what they're finding is the bus routes are limited to 9 to 5, and what would really help them a lot is having that from 8 to 8, for example. So just a stretching of those, but it's again working with those local companies just to get that message across, because it's going to help them with their transport issues. So just wanted to highlight back on that issue around transport, and maybe something that can help, but that's coming directly from those patients, especially in the moorlands area.
Thank you very much for that, Baz. So I've got Councillor Sylvester Hall and then Councillor Norman, and then I think we'll wrap that debate up. Thank you.
Absolutely fascinating with regards to a lot of the content in here. Some of the bits that stood out to me, by 2041, around 1 in 5 adults are projected to be living with one or more significant illnesses. And by 2041, we need 600 million more and 20,000 more staff, potentially. So the do-nothing scenario is not there. I agree with the recommendations that have been put through, but my question was looking at, and I think it's already been touched on by some of the other speakers earlier on, is how we encourage partners to also reflect. It is, for me, that shared responsibility that I think has been mentioned as well. The alternative care packages that are there will come around from those conversations. So it's looking at how do we encourage, if that's the right word, to make sure that we know what we need to do by this time, by 2041. And if I think about some of the aspects that I get involved with from a schooling capacity now, and thinking about the age range of the people who will be in this type of category at 2041, yes, obesity is very much part of it, but I think what gives me more concern, because it doesn't seem to have that awareness amongst the general population, is the impact on young people of vaping at the moment. And that probably gives me more cause for concern as to the age range that we're looking at from now to when we get to 2041. So I'd also put that in the mix as well to keep that at the forefront of the mind. But it is, how do we encourage partners to do that? That's critical.
So I will be circulating a copy of the report to all partners through chief execs, chairs, leaders, and just encouraging them to read it and reflect on it. It's also where potentially this committee can play a role. So when you have health and care services in the room, I hope this report gives you the opportunity to just ask the question about have your strategies, have your plans taken into account the fact that the population is ageing and ageing pretty rapidly. So it's no good just having a strategy or plan that deals with the population as it is today, because in 5 years' time it's going to be different. You know, there are going to be that many more people over 85, over 65. So if it becomes a tool for you to help you ask those questions, then it will have done part of its job as well.
Thank you. It's more just a bit of information rather than any questions, unusually from me at a scrutiny committee. But I did buy the book French Children Don't Throw Food some time ago as a present for somebody else. I did read it first, though. And you got the education in the family there about what is good food, fresh food and so on. And the education committee in Paris at the time, I remember this particular phrase where they're discussing the menu for the children, and French beans and a béarnaise sauce was one of the things that stuck in my mind. Nothing like what we get here in England. I won't say Staffordshire, but in England. So there is ways of dealing with that. And also in Paris, you may have seen recently where the workers there have been asked to have 2 days off from eating fish or meat, which as a vegetarian trying to eat in Paris is something I welcome. For information, Age UK, England now, has the following fact sheets, and I've just checked they're still there, and information documents which the county could actually promote. When someone dies is one, bereavement is another, thinking about the end of life, what is a living will, and the power of attorney court is always important, and if you get onto those things, pension credit is also in there. So there's a lot of information out there, Alzheimer's Society, Age UK, for that information to share. And I was going to mention about the transport being in the next report, but I didn't need to. So there you are, that's it.
Councillor Norman.
Free, by the way.
Thank you. Councillor Atkins, and then I will close this debate.
Chairman, it was something, a lot of the input into discussion debate today has been about people who've already embarked on the journey of old age. The ancient Greeks used to say it was better to die in battle young than to grow old and have all the creaks and pains that I seem to suffer from today. But I'm very aware that the Dilnot report, and we end up going round in circles about this, talked about the three areas, and one is there's people who have already embarked on the journey of old age, and a lot of the comments about the help that's been available to them and taking up living wills, you know, so a lot of the work, that, if that's what it's called, business to business advice in my main line of work in farming is about how you're thinking about succession planning and the business and the issues, and also, you know, should you be doing it and all the rest of it. But there's also a group of people who are probably just beginning to think about it. You know, with my work here on the pensions, people are asking me about, you know, I've got this pension pot. Never about what they're likely to need when they retire. Because hopefully they've paid for the house and they need so much income to live on when they've stopped work. Or are they going to slow down in work? And then there's another group who probably never think that they're going to come round to pension age or whatever, but they may be putting money into pensions, they may not. And the local government pension scheme, which the Chancellor seemed to denigrate, which is actually very well run at Staffordshire, I have to say. It's worth about £7.7 billion now for our members. I encourage anybody who works in local government or any of to put the money into the pension, but also to think about insurance, which is what pensions are for your old age, because nobody thinks that when you're 40, and I use a specific age at 40, that you've got maybe 20 years to start putting money on one side besides your pension and your mortgage, which I hope you've been putting money in since you were 21 or 25 or whatever. The sooner you start putting money in towards old age and you spread the risk and the costs so that you'll be able to look after it. So I think when we're discussing and debating these things, as well as the strategies that you're doing about old age, we ought to be encouraging people to think, and the government and whoever it may be, about long-term insurance in social care and health, so that they know that when they do the other mistake is health is free at the point of entry, but social care unfortunately isn't, that they can think about the ways through it. So there are really three stages, Chairman. Those who have already embarked on the journey, a hybrid, which is a bit like petrol and electric, and then for those that are young enough now and probably paid off their student loan with a bit of luck, and the children are growing up 40, start putting money on one side for social care so that they can spread the cost across all generations and health and everything else.
I probably think there's nothing to come back on that one, unless you wish to, Richard.
No, just a reflection. So I mean, I hope we don't get too many opportunities to die in battle over the next 20 years. I think financial planning is important. I think that kind of health planning is something I'm particularly interested. So helping people to imagine their future selves as they do get elderly and frail, and thinking about what a good outcome from health services would be for them at that point. So all medical interventions have some benefit, and all of them do harm. What's important is the balance. And for many medical interventions, whilst when we're relatively young and relatively healthy, the benefits clearly outweigh the harms. As we get older, what tends to happen is that you get less and less benefit and you get more and more harm. And there becomes a point in all of our lives when actually the harms start to exceed the benefits. And it's starting to plan ahead for that point and thinking about, what do I want to happen to me?
Thank you, Richard. I think there's been quite a healthy debate, if I can use that word, healthy, in this environment. We've obviously reflected the findings of the annual report and concerns of the implications of ageing population. It's obviously that we want to, as a committee, encourage and reflect the findings going forward, and that would consider whether the annual report should be debated further at the full council. I personally would say that it should be debated at full council, because that's the governing body of council for us to do so. So are we happy with those recommendations, members? Yep, thank you very much. So moving on then to item 7, Health Watch Staffordshire Year 2 Progress Update 23-24. A report by the Cabinet Member for Health and Care, which I think was substituted by Councillor Paul Northcott, the Cabinet Support Member, and Baz Tamez and Keith Luscombe. And I know that present we also have from the Health Watch Dave Bassett. So over to you, gentlemen. Thank you.
Good morning, Chair. Good morning, members, and thank you very much for your introduction. As you've already pointed out, Councillor Pert can't be with us today, so he sends his apologies. This is brought to the committee today to, first of all, update you on where Health Watch is in terms on the building on the positive success that's been previously shared with the committee, and to look at working closely with the Scrutiny Committee in terms of where they want that shaped and be a key partner in this, and where we need to go for Staffordshire's approach. And now you'll see, Chair, that there's quite a lengthy support report that's been prepared there with a lot of information that's in there. And the report includes asking committee members to consider and comment on the progress that Health Watch Staffordshire has made during the 2-year period, which previously members have had a chance to look at the 2023 report, and note the further detail in Health Watch Staffordshire recent report, the new report that's there before you. So furthermore, the intention today is to provide an opportunity for members to consider how the committee wishes to further work together with Health Watch Staffordshire. Alongside committee members considering this and the potential to add value to the committee's future work programme, it may be useful to note some existing ongoing link work with Health Watch and the committee, including the focus on West Midlands Ambulance Service, which you've covered in detail this morning, Chair. Just before opening up on this subject further to the committee for thoughts, I'll hand over now to the lead officer for the County Council's contract management system, along with Health Watch Manager, to share some of the highlights from the paper and perhaps distill more points for you to consider. So thank you, Chair. That's me for now, and I'll pass on to Keith.
Thank you, Councillor North. Thank you, Chair and all. So I won't talk too long, so I'll hand over to Baz as well, just to say a few words in terms of the annual report. So just a bit of a brief context reminder, as I'm sure the committee will be fully aware, the County Council is statutorily responsible for commissioning Health Watch Staffordshire as our local health watch, to be that independent organisation and act as a local consumer champion for patients, service users and for the public. Obviously, with a well-performing local health watch and through their consumer champion role, the intention is ultimately to help drive up the quality of local services and improved experience and outcomes for Staffordshire residents and people using our services. As Councillor Northcott outlined, the report today is focusing on year 2 of the current contract and a summary progress update to consider, as well as any further links that may add value to the committee's work programme. In addition to the regular annual updates to this committee, Health Watch produced their annual report again, which I'm sure Baz will talk a little bit more about shortly, and that has also helped inform the papers before the committee today. Health Watch has kind of a clear high-level outcomes, vision and mission as in the papers, and that focus really is around engagement and making sure that all residents can express their views and have their views heard, harnessing that residents' voice to really influence health and care services across Staffordshire and providers and commissioners, and also having an integrated approach around information, advice and guidance, and linking across to the independent integrated advocacy services for Staffordshire as well. So just a couple of brief points in terms of to note for the committee around performance and progress to date, which has been positive across the year from the County Council's perspective and the contract management side of things. So Health Watch has really kind of continued to deliver a streamlined work programme. They've ensured their resources are targeted to kind of have as much impact as possible, and obviously their annual work programme has been driven by community priorities. They've continued to be an important independent voice on a number of key partnership groups and boards, And obviously their crucial role there is to ensure that resident feedback is being used to shape a range of initiatives right across Staffordshire and informing ICS work as well. Healthwatch have directly supported Healthwatch England's national work and contributed to Staffordshire residents' voices and insight on key issues which are also important locally, such as around NHS dentistry. There's been a considerable amount of engagement from Healthwatch and direct engagement with residents around adult social care and working with adult social care teams to inform future commissioning and service delivery. And Healthwatch have engaged, for example, to help inform the County Council's commissioning strategy for older people, and they've also contributed to the Adult Social Care Enhanced Assurance Working Group focus in preparation for the CQC self-assessment. They've expanded the Healthwatch Intelligence Network, and that complemented by Healthwatch's engagement officers carrying out direct engagement with our communities and our residents to obtain feedback, is all very much intended to help ensure that Healthwatch can hear from a range of voices throughout the year. They've completed 3 of their deep dives, and further deep dive work, which the committee will be aware of, is also ongoing in year 3, which we are currently in now. And they've delivered a successful kind of annual engagement programme with direct engagement with local communities, including around West Midlands Ambulance Services, which I'll let Baz talk a bit more to shortly, and obviously is relevant to the committee's conversations earlier today. And final 2 points just to say as well, obviously the Enter and View programme has been delivered effectively, and there's been a real effort to coordinate the approach between Healthwatch and working across to and aligning to the statutory quality and safety teams, both in the NHS and in the County Council, but also importantly with Healthwatch maintaining its independence and use of those Enter and View powers. So I won't say too much more, and as I said, there'll be an opportunity to open it up shortly to the committee, but I'll hand over to Baz just to share a few highlights in terms of the annual report. Thank you, Chair.
Yeah, thank you very much for that, and that's a really good comprehensive overview of that. And just to pick up a few key things, and maybe starting with what I highlighted as well with the transport. As a Healthwatch, we are quite well placed within Support Staffordshire, which is our host organisation. And geographically, we have an engagement officer in the north, covering the 2 districts, and the south, covering the 6 districts, one in the southeast and the southwest. And that gives us that good reach into those areas. And with Support Staffordshire's already existing networks, it makes it really, really easy for us to get into those key places that would otherwise be quite difficult. And just to give an example, when some of the engagement officers will go and engage up in the north, like I mentioned with the PPG groups, you can get good, and carers group and other groups that are going on that Support Staffordshire would either host or be a part of with other VCS groups. What we do know is that when things are going well, we can report those back. When they're not going so good as well, and some of those things are raised about cost of living, was how there are people that would like to volunteer and go and see people or help people with transport, especially with food banks as well. But due to the costs it is with the fuel, that can prevent them from being volunteers and supporting or being effective volunteers. We know some people have to sometimes go on foot to go get stuff, and that can be incredibly difficult, especially if you've got young children or if you're elderly. That can be a big impact. And that's, again, something that we picked up in the north, whereas in the south areas like Kinver and surrounding areas, we have been working with the South Staff's Wellbeing Select Committee, Councillor Paul Harrison and Mark Jenkins, picking up concerns around mental health and cross-border services. So patient choice being central here. What the residents there were raising as concerns were that they were being sent up to places like Cannock from Kinver. The difficulty there is if you've got 3 bus routes to get there, besides the cost that it would incur, it's the amount of time it can take. It can take 3 hours both ways, so you can, looking at almost 6 hours just to make one appointment. You can see how that could be quite a difficult challenge. We have been working with the ICS and partners, including the practice managers across the south, and just looking at where the law stands. So you've got the Health and Care Act 2022 that highlights how important patient choice is. It also, we've talked to partners within the ICB who have assured us there are service level agreements in place to allow cross-border services to accommodate for Staffordshire residents and vice versa. That doesn't always happen, and that's where we're investigating things like that. And these things are really important to highlight for us on many of the partners that we're working with. Just to bring you back to Support Staffordshire very briefly before I go on to the next set of partners. Within Support Staffordshire, they have around 100 staff that are geographically placed across Staffordshire, and are also linked to over 1,000 other VCSE or smaller organisations. We also have Base Camp that gives us that internal way of transferring information and data. And one of the ways that we as a Health Watch will raise the patient concerns is through this platform as well. And that's through our e-bulletins that we also distribute amongst, I'm sure, a lot of people here and a lot of the partners. That gives us a good insight to all the VCSE sector as far as possible to show those key things that we're picking up. And we do tend to get a good response back from partners who will come back to us about certain things. Say, oh, can we raise this as well? Or we've noticed that's going on. You need to be aware of A, B, and C. So it's really, really important that Health Watch Intelligence Network has really grown and having a really positive impact. Just to also say that, we reached about just under 3,000 people that we engaged with through, face-to-face or events across Staffordshire in the year of 23 to 24. We had 6,000 people that we engaged with through our social media and a further 14,000 through our website. We do have 18 volunteers that really support us, of which 7 do sit as part of our Health Watch Advisory Committee, which does really help towards how we work and operate. And again, just to highlight that we are working quite closely with other local health watches such as Stoke, Derby, Dudley, Wolverhampton. We have the regional Health Watch England meetings that take place regularly, and we also work with Health Watch England. And again, some of those key issues that were highlighted, that information is transferred back around cost of living, for example, just to Health Watch England, so they can see the national picture, as well as mentioned by Keith earlier on about NHS dentistry. And these concerns then on a national level are taken back to Parliament to be discussed. It's very important for us to, again, be very integrated into the system. We are integral. We do work with the ICB quite closely. We have found that working with partners, especially on the systems quality group meeting, which is a statutory requirement for that meeting to take place from the ICB perspective. We will, as a Health Watch, attend this meeting on a monthly basis. You do have CQC that attend this, as well as the local authorities, both Stoke and Staffordshire, and the trust partners, and it's chaired by the ICB, and that's Heather Johnston. And we raise an array of themes and trends that are really, really important, all the way from GP access or lack of appointments, those that may be discriminated against for neurodiverse conditions, young people and mental well-being, those from seldom heard communities, whether the LGBT community, also those that struggle with non-agent patient transport, again for dentistry and more. So I will stop there for now, as I feel Keith has covered other parts of that. Thank you.
Thank you very much, Baz. I think the report presented is a very comprehensive assessment of the work that you do, and I think probably speak for the committee. I think we appreciate that. Councillor Edgley.
Thank you, Baz, and thank you for the work that you do. But on page 12 of your report, you talk about the mental health of teenage mental health and the health outcomes of when they've been in care and deep dives, and that, it's Health Watch deep dives. So I just wonder what work was taking place and how you were asking questions on this, please.
Use your mic, please, Baz.
Apologies for that. Yeah, so that particular deep dive was to focus on young people that are care leavers, that are, looking at their mental well-being, good and bad. So kind of an open question, and it was to help support, how Staffordshire County Council is implementing some of those services and how young people are experiencing it. And that's that opportunity where we can ask those open, honest questions to those young people, and then effectively it's like putting a mirror up against, back to those commissioners, and people that are, operating those or delivering those services. Say, this is actually how you're being received. as a whole, the feedback was generally quite positive from young people, and how they especially were getting support around their mental well-being, and the peer support groups that had established between themselves. The concerns that were raised were around transition, so nothing necessarily new there. What tended to happen was at the age of, just as they're coming to the end of 17 into 18, they would transition into adult services. And that particular concern was that a decision was made by professionals to, let's just say, no longer continue. They didn't need that particular service around mental health anymore, which meant there was a break, they weren't involved in it, and then they had to go back into adult services. They felt they needed it and restart the process. And being in adult service is a lot more difficult for them to navigate, and the supports do come away a lot more as you transition into adulthood. So that was kind of the main big area that we were highlighting back to our partners to say what more can be done at that transition point to prevent that negative outcome.
Thank you very much for that, Baz, and I hope you keep pressing the point, because I think that's one big concern out there. Thank you.
Councillor Norman.
Thank you, Chair. So it's a bit random all this, but on the, I won't call them deep dives if you don't mind. I don't use existential and various other things. I'll just say you a detailed inquiry into the seldom heard community, and I'm particularly interested in the three subjects you got there, but the rurality one, by the regarding transport as well. My only question on that, and I've just noticed there's a link to go to the full report, in which the answer might be, and my apologies if it is, but how did you go about contacting those people, is my first question. How did you get contacting those people in the rural areas? Because the people I know that are difficult to get hold of is they won't come out the house, you don't know they're there, they haven't got any family and that. I mean, it's very difficult. So I just wondered how you did it.
Yeah. Yes, that was one answer. Yeah, it was actually a challenge on that one. Again, it was using the existing systems and services. So looking at talking to, within support Staffordshire, they have locality officers that are based in key parts. I remember, especially from that report, one of the things mentioned was, I remember when Emma went out to speak to the farmers, and that comes back to the question of rurality. And one of the questions, one of the things that they raised as issues was, as much as digital is a great idea, they can't get any internet access or phone reception in their areas, so they could be impacted in that particular way. So that was one area that was mentioned. The other one was, again, as already been highlighted, is about transport, the costs it entails. What people would like is, services closest to them, especially minor injuries units. And there's always that fear that might be taken away or it might be difficult to get to. So sometimes they won't engage in services until it's a bit later on, and then that means it impacts secondary services.
Just one more question for yourself, the one for you, Chair, for me. One is about the 23 pence per person. How is the contract, it might be not you to answer that one, how is the contract devised, such as we end up with the figure we have for Staffordshire as opposed to East Sussex or whatever? Yeah, thanks.
Thanks, Councillor. So the decision around that, this predates my involvement in this, but I do know the history of it. So the Health Watch Staffordshire contract is funded through the Local Community Voices grant and also the local government finance settlement that comes to the county council. The decision in terms of budgets is taken at kind of cabinet level, member level around that, and senior officer level, so at senior leadership team. I do know the prior contract to the current contract we were in was the same level of funding, so the 205. I believe before that it was reduced quite significantly, but I'm going back quite a number of years here. I couldn't tell you the specifics on the decision then, but...
With the figure, what's it based on? Is it...
So the rationale for the figure will be around kind of wider MTFS decisions and discussions, as far as I'm aware. There isn't a particular formula for different areas, and different local authorities will decide on what their funding levels are depending on various local kind of circumstances and MTFS discussions, as far as I'm aware. But we felt it was important to include that kind of wider context, as Health Watch England have publicised all of that as well. And I think as well, it gives, in terms of that value for money, I think, as the Chair and the committee have reflected, Health Watch do kind of deliver effectively and are an important kind of part of the ICS and the health and care system and kind of that independent voice. So I think it does adds extra kind of bang for a buck, if that is a welcome phrase or not. But I couldn't give you a more descriptive answer on why the decision was made several years ago around that funding. But
it is really about what it's based on. I mean, you know, the poverty and all these other factors that you have. I just wondered how it was. But if it sounds like it's a bit historical and it all has just been amended every time, I'm not sure that...
Yes, it will. As I said, each new contract frame, there will be a consideration around that funding level, but it will be within the wider MTFS decisions and discussions. So hopefully that answers to a point.
It almost does. I've made a question for you, Chair, well, but for me, obviously there's a lot of information there. I'm still getting through it from Health Watch. A lot of support they give for us, I think, in the way of understanding what's happening in other areas. But what's the best way we use, as a scrutiny committee, what's the best way we can use Health Watch? Is it for evidence, to carry out reports? I just wonder what's the best way we can use forgive the term, use Health Watch. I'm not sure, but that's just me. Maybe it's straightforward, but thank you.
I think the answer to, in terms of how can we benefit, I mean, I think Baz does always attend our meetings, and there's contribution from him, so we're getting that fed into us. Specifically, as within the report states, that we had the healthcare working group, and I have to say, I chaired that, but I would also add that Baz's contribution to that development there, in terms of that piece of work that we did, was enormous. So I think we gained a great deal from it, and I think whatever we can do is whatever is suggested we can take on with on board, so that there is a working relationship that we have. If that's helpful to you, Councillor Norman.
Yeah, I'll leave it there. Thank you.
Thank you. So I've got Janice Sylvester Hall, and then we'll wrap this particular debate up.
Thank you, Chair. Yes, I agree with you completely about it, this being a very comprehensive report. I think there's a lot of information in there, as well about the costings as well. And I think that your phrase about the bang for the buck actually was quite a pertinent one. That was something that came to my mind when I was reading through it. Generally, as a high level, just a question for Health Watch with regards to the level of engagement and across the demographics that we're looking at, but also the geographics. Do you think that it is being able to access the relevant people that we need to be getting the information from when it comes round to the level of engagement and the different type of platforms that you might use to be able to do that? Will be my first question. And then secondly, when you do get this valuable opinion, and I think that when you have qualitative data, then that is something that is extremely powerful. Is it always welcomed and valued by some of the partners that you might be engaged with?
Yeah, thank you for that. That's why I was writing it down, so I don't forget. Yeah, I think in terms of access, we do get access quite easily, actually. We are well received by most partners. You know, in fact, sometimes, like, for example, MPFG reached out to us and said, oh, we know you've got your enter and view powers, our statutory powers. We do our internal quality assurance visits on the different sites, on the wards and the business centres. Could we do it jointly so we can assure that we are doing it properly? And that's worked out really, really well. That's given us easy access into places. Effectively, if we were to arrange an enter and view by ourselves, it would take a little bit longer, a lot more work for, to work with them to get that right. They're already doing this. They've done all that legwork already, so we just come in on the day and we can do that visit jointly with them and then give them that soft intelligence perspective feedback, which at the moment, I would say from all the reports we've done with them, does actually complement how they're doing their work. It's not totally off. So that's been really, really handy, and we try to reach out to other trust partners to also encourage them to do that. And though they have assured us, we're still working with them to kind of pick up that way of doing it. In terms of, like, for example, the PPG groups, the carers groups, numerous committees and boards that we go to, everybody really, really welcomes it. At times, yes, there are things we will say that may upset somebody. You know, again, sometimes that could be what we present or how we present it. But the key question we always ask, and we do operate, I suppose in a way a safeguarding look would be, because when things go wrong, and as I've said before, so when things go wrong is often when people aren't, or patients aren't being listened to, or when systems aren't talking to each other, and usually it can be because of GDPR issues. I always have that question, I'm sure the team and the Health Watch team has that question. If we don't say it, does that mean somebody gets harmed? So it's that, you know, sometimes, yeah, we will. Our intention is never to upset anybody, but we will probably upset somebody somewhere down the line. But it's better that, and we have a good outcome for somebody.
Thank you. Well, thank you, gentlemen, for the report. I think for committee notes the content of it. I think we've appreciate the very hard work that goes into with Health Watch and value its contribution in the process. So I think that's brings that item to a close, and thank you for very much for your attendance. Thank you. So
thank you, Chair.
Item 8 is the work programme. Obviously, I always say it's not the committee's, it is your work programme. So our next meeting is the 28th of October. We got the ICS and People Workforce, Staffordshire Social Care Workforce Adult Social Care Update, Freedom to Speak Up, which is an extremely important subject, and an update on a report from the Women's Health Working Group. So that's for our next meeting, and then we've got December the 2nd, January the 27th and 3rd of March and 7th of April, which would conclude this municipal year's agenda items. Are there any other items that you wish us to perhaps look at or consider? Councillor Jessel.
Just wondering, in view of the predictions that there's going to be a bit of a triple whammy of flu, COVID and RVS, is it RSV? RSV virus going round, whether for the next meeting or the December meeting we could just have a briefing note on what vaccination rates are, because I think it's going to be potentially a big problem this year, and I'm not sure whether there's been a big enough push to get people vaccinated.
I'll go for that next.
Would you want that to come to committee, that briefing paper, or just be circulated to members?
I think probably just circulated to members. If the outcome is that, you know, the take-up rates are low, then I think we would need to have somebody here to explain why and what they were doing to address it.
Yeah, we will take that on for sure. Councillor Edgley.
Thank you. Seeing as we've had this discussion with Richard this morning about, you know, ageing population, I just want to make sure that anything that he's suggested that we should be looking at is in our work programme.
Yeah, so I mean there are a couple of items that are coming up. I think some of the points that Dr. Richard Harley wanted to raise, it was just for you to be mindful of if items come up. So, for example, at our next meeting we've got the workforce coming from adult social care. So again, that can be some of the issues that have been raised. They can be raised then, and it's as and when other items come up. If there was anything, of course, specific that you and the committee wanted, then that could be added.
Councillor Jessel?
Yes, I was just thinking, you know, it was raised about can we raise the profile of living wills, etc., etc. You know, I think it's something we could look at, because I think it's something the county council is seen as a fairly neutral body in terms of advice, etc. the website has been upgraded so it's easier for people to navigate their way. You know, you mentioned lasting powers of attorney to people and they think they've got a huge legal bill. Well, you don't. They're a rather protracted set of paperwork, but it's not that complicated. And I think it's something that as an authority we could raise the profile, make information easily accessible and understandable at no real great big cost to us, but it's something that, you know, we could add to it. So it may be something that, you know, as a committee, we could ask somebody to come and say, well, look, can this be done? And because...
Yeah. I think that is very important that you raise that, Councillor Jessel. And I think that's probably where a working group, where we've got on here the end of life, that tries to take in all of those items that are very pertinent towards. Yes. Yeah. Yeah, thank you. I think it's very important that people do wills. So I think on that note, oh, Councillor Norman, I do apologise.
That's all right. It's not to add anything except I'm afraid to inform you that I'll be here at the next meeting as well. Maybe the one after that. Now I was told is because my colleague couldn't get a babysitter and I offered to babysit, but that wasn't on. I now realise it's the roadworks. But her excuse is looking after a child, you know, the new one. I'm just saying, so I'll be here, just letting you know, that's all. Might ruin your day, but I'm letting you know.
Thank you, Councillor Norman. We'll always have you, pleasure to have your company. So, on that note, I formally close the meeting at 1 p.m. Thank you for your attendance.